national webinars. This one is focused on challenging retinal surgeries. And this webinar, titled "The 7 Surgical Samurai and 1 Sensei," promises to be as much of an epic blockbuster as the iconic 1954 Akira Kurosawa movie from which it takes its name. So our sensei today is none other than the surgical stalwart, Dr. Steve Charles, a pioneer in vitreoretinal surgery, a prolific innovator, and above all, a great teacher. 7 surgical samurai, experienced surgeons from different parts of the country, and they will be sharing their experiences of various complex retinal surgeries. Along with Dr. Charles, it's my pleasure to introduce our panel today. Dr. Shobhit Chawla, President, Vitreoretinal Society of India, also Director of Prakash Netra Kendra, Lucknow. Dr. Giridhar, former President, VRSI, Director, Giridhar Eye Institute, Cochin. Dr. Natarajan, former President, All India Ophthalmic Society and VRSI, and Director, Aditya Jyot Eye Hospital, Mumbai, and one of our more globally recognized retinal surgeons. And Dr. Pramod Bende, Director, Retina Services, Shankar Nethralaya, one of our premier retina institutes. And moderating the session along with me will be Dr. Raja Narayanan, Honorary Secretary, Vitreoretinal Society of India, and Director, Clinical Research, LV Prasad, Hyderabad. I would now request our President, Dr. Shobhit Chawla, to say a few words about Dr. Steve Charles. Ironically, both of them share the same initials, and both are multifaceted personalities. Dr. Shobhit, as we know, is an amazing chef, poet, and philosopher. So, Dr. Shobhit, please.
It's an honor to introduce Dr. Steve Charles, whose name is synonymous with modern vitreous surgery. He is the founder and head of the famed Charles Retina Institute, Tennessee. He's authored leading textbooks. Most of us are familiar with one of his textbooks, which we have all read and gained during our fellowship years. He has over 200 publications. He has pioneered various surgical techniques. He's a prolific innovator and was named so by the Ocular Surgery News as one of the top 10 innovators in the last 25 years. He has received multiple awards. He was the Founders Medal at ASRS. He has been honored by the famed Jules Gonin Club and American Academy Laureate Honorary. Delivered the Charles Kelman Innovators Lecture at ASCRS. He was inducted in the University of Miami School of Medicine Hall of Fame. A mechanical and electrical engineer, around 150 issued or pending patents. He has a major hand in developing the Accurus and now the Constellation systems, and more to come. He flies a Falcon jet and a Sabre jet, and he will be enlightening us with his keynote lecture today on the management of complex detachments. Thank you, Dr. Steve Charles, for being with us. It's an honor.
Thank you so much. I feel so close to my friends and colleagues in India. I've, of course, been there many times and have had many visitors. And it's a very special relationship that I believe I have with the Indian vitreoretinal community, as well as the nation. And my heart goes out to your country for the pandemic crisis that I know is so hard on so many people, especially people that are poverty stricken. And we feel bad for that. Let me share my screen and we'll get on with my talk here. Complex retinal detachments, there's no hard definition of what's a complex retinal detachment. So I listed the 3 things that are more difficult for all of us: giant retinal breaks, PVR, and diabetic traction retinal detachments. And I'm going to take them in that order. And the notion behind the talk is, instead of giving history and statistics and showing pictures and videos, I'm going to list what I think are crucial mistakes people make that I see over and over and over again when people show videos and they call me on the phone and email me about their cases, or I'm visiting professor. So I'm going to list the mistakes that I see made over and over again, at least in my opinion, they're mistakes. And I'm going to list what I consider the essentials to doing a good job in these challenging cases. So with respect to giant breaks, the biologic problem is PVR, but the surgical problem is retinal slippage during the exchange process. We all know that Stanley Chang brought us liquid perfluorocarbon, which is absolutely magical to put the retina back where it belongs, and we're so indebted to Stanley Chang's work. So when you then exchange it for gas or silicone oil, often the retina will slip. This is technique driven, as David Wong has emphasized. If you're meticulous about the technique, you can get around it, but it means that you have to put the cannula at the interface in the far periphery, and that does lead to lens bumps. And if you do phaco and break the capsule, you've created another set of problems. So what I've used for all inferior detachments, as well as all inferior temporal and nasal giant breaks, is what I call medium-term PFO. We all recognize that perfluorocarbon was approved as an intrasurgical tool, not as a short or medium-term tamponade. I do not use the so-called heavy silicone oils. They create an inflammatory process. But what I've done for over 21 years in over 1,000 cases of retinal detachment is to leave the PFO in. Now, clearly that won't work for a superior retinal detachment, but for a temporal or nasal giant break, the patient can lie on their side. It works absolutely great. And there's no slippage because you're not exchanging it. For inferior, it's perfect because the patient can stand up, walk around, go to work, fly in an airplane, unlike a gas bubble. So I use this medium-term PFO technique for all my inferior detachments, but it's particularly advantageous for inferior temporal and nasal giant breaks. What are the essentials? I do not believe in using multiple spots of laser in any case. This is an anachronism that comes about from cryo or even diathermy where you can't move the probe. There's no reason for spots that are separated or multiple rows. You have a far more uniform adhesion between retina and RPE if you use confluent lasers. And the confluent laser sort of smears the thermal profile, so it evens it out, whereas a normal laser spot's hot in the middle and cold on the edges. Always excise the anterior flap. And this is analogous to what I'm going to talk about in retinectomy and PVR. Scleral buckles are bad news for these patients. They actually encourage slippage. There was sort of an insider joke years ago. Machamer would do a buckle on the PVR cases, write a letter, say the retina is substantially reattached. Yeah, that meant attached on the buckle, but not behind the buckle. People don't see with their equatorial retina. I'm sorry. There's an obsession with combined phaco. If you've got a 20-year-old, they're not going to get a cataract from vitrectomy. Nuclear sclerosis progression is the rule. Clear lenses remaining clear is the rule. So only use phaco if you can't see what you're doing. Do not use a short needle, a half-inch needle, to inject the PFO. It causes multiple bubbles, and they end up getting in the subfoveal space, which is bad news. If you use the Med1 cannula, which I did not invent and I do not have a royalty on, I have no financial interest in Med1. The Med1 dual bore allows you to have a normal interocular pressure because there's a fluid egress path, and now you can inject with this flexible polyimide cannula at the right level. And we'll talk about that, but in a moment. And excessive retinopexy, instead of saying this is a bad case, we got to do more retinopexy to hold the retina down. Don't do it. Cryo is terrible. It causes PVR and it causes slippage of the break. So when the dual bore cannula has an egress channel, and so you should start with the tip of the dual bore cannula at the optic nerve head, make a small bubble, and then keep the tip of that yellow cannula that you see there, the pale yellow transparent cannula, in contact with the top surface of the bubble, and slowly withdraw as you inject. If you do that, you won't waste this precious, expensive PFO, and you will have a full fill without multiple bubbles. I use only the Alcon perfluoron. As some of you may know, there was a batch of PFO from India that was toxic. I don't use perfluorodecalan. I don't have any evidence that the perfluorodecalan's bad, but the index refraction isn't as different as it's just not as easy to see because the index refraction. So obviously the subretinal fluid, as well as all infusion fluid and liquid vitreous, all floats to the top, and you want to get rid of absolutely every drop of that. So people say, oh, you mean I can do a full fill? You must do a full fill. Oh, I'm afraid to do a full fill. Why? What do you think is going to be the problem? If you fill it all the way to the back of the lens or the IOL, or in the pseudophakic eye, fill it almost into the anterior chamber, then you have less aqueous material, whether it's aqueous humor, liquid vitreous, or infusion fluid left over at the end of the case to cause slippage. So full fill, mandatory. And this emphasizes that point with the word complete on the left. And you can see how as I finally filled it near the top, there's a very flat angle to this cannula, so the egress channel, and actually rotate the eye over a little bit so I get the last little bit of fluid out. And this shows the confluent laser that I emphasized, and the excision of the anterior flap was not well depicted there. What about superior giant tears? Well, you have two choices. You can exchange for oil, which you must do if there's PVR, or if there's no PVR, you do have the option of exchanging for gas. And but how do you do that? You don't have three hands. So you either use chandelier illumination, which has the problem of glare, but you can use the malleable Alcon one and aim it in the right place. I always use the Alcon VFC on the console at 80 PSI to inject. The other option that I only began to do recently is slower, but it allows you to do three-port without a chandelier, and that is Med1 makes a PVC tubing instead of silicone rubber that snaps over a non-valved infusion Alcon infusion cannula. So that works real well, so that you can have the extrusion cannula in the other hand and the endo illuminator in one hand, and have sort of standard technique. So I tend now to use that method. I don't use it in PVR cases because it's much slower in terms of the oil injection rate than the method in the first bullet point. Again, it's extremely important during the exchange to do sort of the inverse of what I described with the injection process. And that is, and this, again, something that we must credit David Wong from Liverpool, and that's to keep the tip of the extrusion cannula right at the oil or gas interface with the PFO in the periphery. So there's a meniscus of BSS, subretinal fluid, and liquid vitreous there, a little thin meniscus. You want to get rid of every bit of that. What I've seen people do is put the soft tip cannula at the optic nerve during the exchange, and sure enough, the retina slips back, and now they're trying to manipulate it mechanically and bumping the pigment epithelium and causing PVR or having to start over. So it's very, very important to do this exchange properly. This is where mistakes are made. To do that, you must focus down. I use only Ingenuity for visualization, but whether it's Ingenuity or the microscope, you must use the highest magnification and follow focus. I used to work in TV. I put my way through engineering school being a TV engineer, and we call it follow focus. So you follow that interface between the PFO and whatever you're exchanging for, gas or oil. So you keep that extrusion cannula tip at the interface as it moves down, again, in the periphery, because the fluid meniscus is thicker in the periphery than it is centrally. So you don't want to be at the apex like you are when you inject. So this shows you that technique of exchanging and removing all of this BSS. Now let's switch gears and talk about PVR, so I don't run out of time. I invented retinectomy exactly the same time Macomber invented relaxing retinotomy. And we presented at the same meeting in Los Angeles. Often Macomber is credited with inventing this because of his prominence in the field, but in fact he didn't. But what matters is not who invented it, but how to do it properly. What's the difference? There is a substantial difference. Macomber made a circumferential cut and left all the tissue anterior to it. If you look at the silicone oil series, there was a 22% incidence of hypotony. That is absolutely caused by bad technique, namely heavy cryo, buckles, and more importantly, leaving this anterior tissue. So when you make a circumferential cut in the retina, excise everything anterior to it, just like in a giant break, you excise the anterior flap. If you leave that tissue, for one, if it's anterior to a cut, you can't see with it. The notion, well, it might cover the pigment epithelium. It doesn't. It scrolls up and it covers the ciliary body and causes a point Machamer made. Machamer from German used the language Ringschwelle, and that's residual capsule, cortex, peripheral vitreous, anterior retina, all in one ring that runs around the eye. That's what leaves the epiciliary tissue. I polled my ex-fellows via email and asked them, how often have you seen hypotony from my PVR cases? Not one person could remember a single case. And I go to meeting after meeting where they talk about endoscopic surgery to remove the tissue on the ciliary body. Doing Machamer's relaxing retinotomy technique is a major cause of that. It also causes more PVR, as John Lean and I have reported. Don't do a scleral buckle. Scleral buckles, patients pay money for, or it doesn't, even if they don't pay money for, it doesn't matter. They want a good refractive outcome. You induce around 3 diopters of axial myopia when you encircle. There's no randomized trial evidence that a buckle improves the outcomes in PVR. Day in, day out, I reoperate other surgeons' PVR cases that they send me or somebody else sent me, and there's a giant buckle in the eye and all the retina's detached posterior to it with PVR all over it, and the breaks are posterior to the posterior edge of the buckle. It makes glaucoma filtering procedures a nightmare. It causes ocular surface disorders. It causes strabismus. I've done 8,000 vit buckles, but I got over it and I learned not to do it anymore. And I haven't been doing buckles, period, for around 15 years and maybe more. And that's important. So if you do a lensectomy, don't leave the capsule because you're going to put a sulcus lens in later. The capsule sticks to the back of the iris. They get a concave iris. They have more epiciliary tissue and more hypotony. Excessive retinopexy causes PVR. Don't say, oh, this is a very challenging case. I got to do 6 rows of laser. Don't do it. If PVR comes back, don't take the oil out to reoperate. I've reoperated all my PVR and epimacular membrane cases under oil for over 30 years. It works absolutely great. It takes a short amount of time. It's less traumatic on the eye. There's many, many advantages to reoperations under oil. I've seen patients that have PVR with oil in the eye, recurrent PVR. The doctor takes the oil out, puts PFO in, which promptly goes underneath the retina, and then at the end they put the oil back in. What are they thinking? What's that PFO step supposed to be for? There's absolutely unnecessary to do that. Sorry, let's go back one. So what's the sequence of events? You always initiate in any detachment case internal drainage subretinal fluid, which I invented, before you do fluid air exchange. Always drain first. Then as the retina goes back under air, it may hang up and you say, oh gosh, I missed some vitreous. Don't start over and put fluid in the eye. Do vitrectomy, interface vitrectomy under air. Then you go farther back. You say, oh, there's a star fold I missed. Let's peel membrane under air. Then the retina goes farther back. Oh, the retina's, now that I see it, the subretinal fluid was turbid. I couldn't see it before. Now some of it's removed. I can see there's a subretinal band. Let's remove it or resect it. Then as you finally get back farther, that's when retinectomy is performed under air. Don't do retinectomies under saline. That's important. So I call this generically interface vitrectomy, under air, under PFO, or under oil. Now we know obviously that air and oil float, so the word under is in quotes. But what are the scenarios? One, the one I just described, where you notice traction during fluid air exchange. 2 is if you noticed it after you put PFO in. I often do some more vitrectomy in the periphery with PFO in the eye, being careful not to be in the PFO space and remove it. If the retina is highly mobile, jumping around, making you nervous during vitrectomy, and this is much less common with the 10 and 20,000 cut per minute cutters. But anyhow, if that point you can put air in and it'll work. If you have bleeding and traction detachment surgery that just you can't seem to stop it by raising the pressure, put air in, the bleeding will be confined to the retinal surface, and you can at least finish the vitrectomy under air. All retinectomy should be performed under air, not PFO. And then, as I said, all silicone re-ops should be done under oil without taking it out. How do you do that? If it's a epimacular membrane, you don't even have to add oil. If there's a subretinal fluid, then obviously you've got to inject oil as described here. And this shows you membrane peeling under oil. And this shows you an epimacular membrane under oil, and you just top up the fluid if there's a little shortfall. What about diabetic traction detachments? We only got a few minutes left, so I'll talk quickly. The notion that there's a linear algorithm, first do a core vitrectomy, then make a PVD, then do membrane peeling. That algorithm, one, is way too rigid and has nothing to do with diabetic traction attachments. Don't do forceful PVD creation. It causes iatrogenic retinal breaks. And membrane peeling is totally unnecessary. So what do you do? Well, scissors delamination and cutter delamination are what you should do. The second common mistake I hear over and over again, people say, oh, with today's multipurpose cutters, there's no need for scissors anymore. And I said, well, how often do you put in oil? Well, these, are complex traction attachments. I usually use oil. What are they telling you? They're telling you they made iatrogenic retinal breaks. If there's no retinal breaks, there's no need for oil. If you're using oil commonly in diabetic traction attachments, frankly, you're not doing a good job. So you must use curved scissors in addition to the new beveled cutters. The cutters are way better than they were even 5 years ago. I love the Alcon 20,000 cut per minute bevel cutter. I can do more and more epiretinal membrane, but not all. You must have in your armamentarium the ability to use curved scissors for delamination. It's an essential. Don't use diathermy before cutting things. Wait until you delaminate with the cutter or the scissors. If it bleeds, elevate the pressure. If it doesn't stop, then use the laser for hemostasis. And there's absolutely no need for a buckle in these cases or for viscodissection or bimanual surgery. If you use disposable scissors, which means you then won't contaminate and cause toxic posterior segment syndrome from bioburden, then the scissors work well, and I find no need for bimanual surgery to stabilize. Bimanual surgery is not necessarily bad, it's just unnecessary. There's two types of delamination: fold back for flexible membranes and conformal. And this is what they look like. So if it's a rigid membrane that won't fold back, you've got to put the port right at the margin of the epiretinal membrane. You can't pull it up into the port. If it's flexible, you can put it on top of the membrane, behind the edge of it, and it will fold back into the port. Both those work. But they're for different. This is rigid, flexible. So when do you need scissors? When the membrane's adherent to the macula, that's a tabletop traction attachment, typically, or if the retina is very thin and atrophic, which is more often nasally or in mid-periphery. So if it isn't necessary to remove every bit of epiretinal membrane outside the arcades, but if there's membrane that's causing the macula to be elevated or folded, then you got to do something about it. And if it's adherent to very thin atrophic retina from ischemia or from a chronic TRD or from prior PRP, then use the scissors, because if you use the cutter, you're going to make iatrogenic retinal breaks. Why is silicone oil bad? Because it has a very low oxygen extraction ratio. It confines cytokines like basic fibroblast growth factor and VEGF, and causes Mueller cell reactive gliosis at the retinal surface. When should you use vertical scissors? Never. Curved scissors are better for everything. The back wall of the eye is curved. Vertical scissors require more space to get in the potential space between membrane and retina. Always use curved scissors. What's segmentation for, which I invented? It's for access to the delamination plane by and large. Should you stick it in and open them? No. Should you stick the scissor tips in wide open and then close? No. Make small snips. Don't do this. Don't spread. You'll tear. make small snips at the margin as depicted here. What's the direction of delamination? Inside out is better. Start at the nerve, delaminate along the arcades. The retina is stronger, you can see what you're doing. The surgical planes are more visible there. Outside in causes more breaks. There's room for outside in on occasion, but instead of starting at the outside edge, outside the arcades, where you're more likely to make a retinal break, start at the nerve head and delaminate outwards in most instances. This shows you inside out delamination with a 25 gauge curved scissors, and this shows you removing the sheet. This makes the point that instead of you must make a PVD first, then deal with the retinal surface is wrong. If there's not a PVD, don't worry about it. Go centrally, delaminate inside out, and the outer margin of epiretinal membrane will be contiguous with the posterior vitreous cortex, and you can safely remove it then. Where does this fit? If there's no PVD, don't make one. Delaminate inside out first. It was called en bloc by Gary Abrams and a number of others in Milwaukee at the time, and en bloc is a stupid term and a stupid concept because the original en bloc paper by them, I invented delamination, and I invented delamination before the PVD if you don't have one, but they went ahead and published it, put a different name on it, en bloc, but they were wrong on what they advocated. They said use the posterior vitreous cortex to pull on the membrane, which is a very bad idea. And the en bloc comes from cancer, where the point is to remove it in one piece. That's what en bloc is translated from. That means in a block, one piece. That's not what you want to do, because you're going to create remote traction. So it's very useful to do segmenting the delamination, segmenting into a couple pieces as you delaminate, so you're not pulling on the supratemporal arcades or the fovea when you're working on the infratemporal arcades, as an example. Peeling has no role. If it happens, just come off easily, fine. But don't start with picks and manipulators and spatulas thinking you can peel. Peeling's for macular surgery and PVR. And lastly, don't use diathermy for hemostasis. Use the laser. I published this years ago. The green 532 nanometer laser energy is absorbed in the hemoglobin blood column, which obviously green light's absorbed in red. This way, the energy is confined to the blood column, whereas there's collateral damage with the radiofrequency energy of diathermy. Well, that's all I wanted to cover. I guess I didn't run over with time, but about 2 minutes. I guess we're okay. So thank you so much.
Thank you, Dr. Charles. That was an amazing lecture. A lot of great points to learn there. I wanted to ask you, one question. A lot of people, if they still see a residual pucker after macular tractional detachments after doing the peeling, do you do regularly ILM peeling with BVCs?
I did not do that for years, and I was mistaken. Your point is well taken. I use Brilliant Blue and the ILM forceps on the diabetic traction detachment cases now. I should have always done it. I only caught on to that in recent years.
I think, as usual, you're amazing, and we used to follow your book from 80s as we particularly liked your logarithm, and you always made, I think we used to call the Bible of vitreous surgery in 80s in Shankar Netralaya. And I think your first visit was in 88 to Chennai and Mumbai. And I think from that time, I think you're always clear in your concept. And I think one of the greatest things which many people don't do is you have propagated that vitrectomy and rear. Sometimes I use that technique for particularly basic excision, and also we are doing a relaxing retinectomy after you.
Dr. Charles, we are also in favor of retaining the lens in young phakic giant retinal tear patients with clear lenses. I would like to ask you, in this temporary tamponade technique of 2 weeks, when you do a complete PFO fill in a phakic eye, how do you achieve a complete PFO fill in a phakic eye by the technique where you describe removing from the interface the fluid?
I've used that Med1 cannula, and I rotate the eye. Typically, I rotate it nasally so that because it's easier to hold the cannula temporally, and so that port, egress port is just inside the supratemporal cannula. So the last bit of fluid, clearly there'll be a little tiny bit of fluid, but I mean very little. When you look at them on the first post-op day, you'll hardly see the superior meniscus, but you must rotate the eye nasally a little bit in order to, and use that Med1 cannula. If you inject with a short 25 gauge or 27 gauge needle, there's no way you can get anywhere near a full fill.
Dr. Charles, another technique described and used sparingly actually is viscoelastic dissection of tight membranes on the posterior pole. Do you advocate that? Have you tried it? What's your comment on that?
Well, I don't use it and I don't like it, and I'll tell you why. I recognize that Maria Baracol was an advocate of it, diabetic trash attachments, Kirk Packo was an advocate of it, but what's the problem? For one, to get a cannula that's shaped properly, that's kind of flat like a hydrodissection cannula, and in the right orientation, you can't get it through the cannula. So now you don't have a real good device, one. Two, it adds cost. Three, it confines basic fibrovascular reactive Mueller cells at that retinal surface. So in my opinion, I can't prove it. I think there's a higher incidence of recurrent glial proliferation, which we now call reactive Mueller cell gliosis at the retinal surface. So I don't do that. And then lastly, you can have, when you stick the cannula in there, you can create a hydraulic retinal break. Just like when you inject saline under the macula, it'll blow through the fovea. This is sort of the inverse of that.
Charles, why are you against a bimanual dissection? I mean, when you have high...
Well, I'm not, okay, there's two reasons. One is that, it's three actually. First of all, let's define it. If I were to do it, I would use a forceps in one hand and a scissors in the other, or a cutter. But people that use a pick in one hand tend to do membrane peeling and pull on the diabetic traction attachment. The point of it is to not pull, because the tensile strength of retina is 1/100th the tensile strength of the membrane. But secondly, with a chandelier, your visualization isn't as good. Oh, man.
Are there any questions?
Sorry, my machine, there's a tendency, if the organizer clicks a certain box, then right in the middle of the presentation, Facebook comes up and says, do you want to log in? I apologize.
We didn't see anything like that.
So
okay.
Anand, I have a question. So again, excellent presentation, Dr. Charles. I heard you talk about retaining PFO in the eye, especially when you have GRT. I wasn't sure if you were mentioning about retaining a complete fill of PFO, or were you talking about sandwich of PFO and silicone oil or gas? If you have ever tried PFO silicone oil sandwich, if I've seen in some cases that the oil and PFO kind of get mixed up if you try to remove it after 3 weeks or so in some of the cases, and the PFO becomes viscous and heavy and it becomes very difficult to remove it. Have you experienced anything like that?
Well, I don't use the sandwich, but that's the reason I don't. And how do you make oxane or Denseron 68? By mixing dimethylsiloxane, which is silicone oil, with either N-perfluorooctane or the perfluorodecalan. That's exactly how they make the heavy oil, the so-called heavy oils, and it makes sort of an inflammatory. I've heard people use the word sludge. So I'm not in favor of the sandwich technique for exactly the reasons you said, and I don't do it at all. I do a full fill with PFO. I put them on topical Durezol, which is difluprednate, unless they're a steroid responder, and I'm rigid about the 14-day removal period.
Yes, I had one question again related to PFO. You mean it's you're talking about octane or hydroxyphenanthrene when you leave behind?
I only use Alcon perfluoron, which is PFO. That's why I use the abbreviation PFO. I don't use Denseron 68. I don't use oxane, and I will never use those.
Yeah. So there are a couple of other questions. Anand, you can just have few.
There's a question from Dr. Ajay Arora. He asks, do you do any retinectomy at all under fluid? If yes, do you use any cautery before retinectomy?
two parts to the question, actually. I always, unless it's a strange trauma case where the retina is sticking in a trauma wound, or I operated on this famous CEO that a guy tried to drain a choroidal and the retina was sticking out the outside of the sclera. So, okay, I can, in those instances, it's quite obvious you got to cut something. So I've done that under fluid, but 99 times out of 100, it's done under air incrementally, like that multi-part graphic that I showed. And if I see big vessels that I've got to cut, I will treat with the diathermy. If I've made one error, it's in the retinectomy context, it's not pre-coagulating, but I don't coagulate all along the edge. I'll treat a big vessel if it's clear that I've got to cut that big vessel, so that way I won't have bleeding.
I think there's another question that's come in. Can a small retinal hole at the base of the fibrovascular proliferation during surgery be left alone without oil or gas with a barrage laser around it?
I'm not a fan of that approach. If it's a diabetic traction attachment we're talking about, and I suspect that's what the questioner meant, what I do is if there's a hole, an atrophic hole that was present before, or if you make a little hole, I've got to get rid of the proliferation around it so I can get it in contact with the pigment epithelium. But remember, when you do a vitrectomy, you have permanently reduced the viscosity 800-fold. That's why the partial pressure of oxygen goes up 12 millimeters of mercury. That's why there's invariably nuclear sclerosis progression, but it's also why the slightest pinhole can result in a retinal detachment. I wouldn't be surprised if you can get away with the barrage laser technique on occasion, but I don't want to rely on it. These patients have diabetes, they're on dialysis and hypertension and multisystem disease, and I want to get them fixed when I'm there. Therefore, I will, but I try it as hard as I can to not use oil in the diabetics because of it prevents oxygenation of the retinal surface, and it doesn't allow you access of anti-VEGF treatment afterwards.
In the inside-out technique, Dr. Charles, do you ever use a mini titrated traction to the attachments of the posterior hyaloid at the disc to create a potential space, or you just straight away start with the scissors?
I like the way you said that. Now, I will on occasion take the forceps and lift just slightly over the disc so I can put the scissors in, exactly as you imply. So I'm delighted you asked that question.
So Dr. Charles, I think we're kind of done with our discussion time here. We'll move on to our national speakers, and we'll go one by one, all our different topics. I'd like to now invite my friend and colleague, Dr. Saravanan from Aravind Eye Hospital, Coimbatore, senior consultant, huge amount of experience, to present on diabetic macular tractional detachment, and we'll see a variety of techniques. Dr. Saravanan, can you come on and share your screen?
Thanks, Anand. I think the video is being played by Sai.
Yeah.
Yeah. So please go ahead, please.
Sai.
Once again, Dr. Steve Charles, nice talk. Mentioning about a lot of your tweaks in performing various steps. It was a nice, entertaining, and enlightening talk. Thank you once again.
Thank you.
Is the video running?
Not yet. I can't see the video, Sai.
Sai, can you start the video?
Yeah. So mainly I'll be talking about managing diabetic tractional detachments. So there, as Dr. Steve was already talking about, we have the outside-in technique as well as the inside-out technique. Both can be used in different scenarios. So in a patient with no PVD, like in this case, a young diabetic, here I was not able to use the cutter to create this nick. It was very tight and taut hyaloid. So I used a small sharp pick to create an initial rent in the hyaloid. and then started using a cutter to sort of move it from the center towards the periphery. So this is a little bit useful when you have very tight membranes with no PVD or very simple membranes. So all the epicenters or where the membranes anchor to the retina around new vessels, I just sort of isolate it by doing a segmentation around it and then trimming off the small bits of twigs which are arising from that. So in this, this is useful when you're having simple membranes or very taut membranes like this. And sometimes this inside out technique, when you're peeling membrane from the disc area, can have severe bleeds like this. In this case, you have to assess whether the bleed is because of ruptured new vessels or accidentally ruptured retinal artery or a venule. So usually raising the pressure will be helpful to stop this bleeding. And sometimes you may want to put pressure a little bit. If it's bleeding in spite of raising the pressure, you may want to put pressure on the disc where the bleeding is to stop this bleeding if it's bleeding heavily, but most of the time it's not necessary. So nasally, when you move around, you have multiple small attachments because the vessels are more crowded here. And you should not lose your patience or don't get excited about finishing of the surgery. So go about in a slow way and manage this. When you are moving from the outside in, you have to first make sure that you enter the surgical field. So you have to talk about the second membrane. Here you can see the top layer is the PVD and the yellow orange marks are the small second membrane which is lying on the surface of the retina from the centers. So in these cases, unless you address the second membrane and go below this, your surgical plane is going to be difficult to peel, as well as you'll not be able to control the bleeding also. Sometimes the second membrane is very loosely adherent, as you see in this case. Just suction using the cutter will be able to pick up this membrane and get it to surgical field. So what looks like a plug attachment or a tabletop big plug-like attachment will actually be multiple point attachments once you enter the sub-second membrane plane. Here, suction was able to lift up this membrane. And so now I do the so-called conformal delamination using the cutter. You cut in small bites going around and lifting the membranes and creating a plane there. And whenever you have some tougher attachments, you may want to switch to scissors to prevent iatrogenic retinotomies. So in patients where the second membrane is very tightly adherent, like in this case, you may want to use a pick to initially identify this edge. So once you start lifting with the pick, you can see that it's shiny membrane. So sometimes it's way peripheral than what you imagine. So this will help you to identify the edge. And once you see the edge, then you can go on with your forceps to lift this edge and then deal with the attachments either with scissors or with cutters, depending upon how thin the retina is, how severe the attachment is. Here I'm using my scissors to prevent iatrogenic retinotomies. A lot of young surgeons avoid the usage of scissors. As Dr. Steve Charles pointed out, scissors is a great instrument to prevent iatrogenic retinotomies. Using only the cutters in thin retina or tougher attachment is going to create multiple retinotomies, warranting you to inject oil at the end of surgery. So here I can see that even though it's a very flat attachment and the retina is quite thin because of the extensive sclerosis of the arterioles and the venules, it's a very advanced renal failure patient and a young diabetic using IDM, insulin-dependent patients. So here you can see that I'm trying to peel the membranes and go around releasing all the membranes around the disc. This was only, the membranes were all confined to the disc. So when you're peeling at the disc, you make sure that your movements are tangential rather than anterior-posterior. This helps you to assess what is underneath to prevent any iatrogenic tears in the peripapillary area or rupturing of the major arterioles or vessels. Whenever you feel the adhesion is very strong, always don't hesitate to switch to scissors. This will give you a much more safer dissection without creating retinotomies so close to the critical areas here. Sometimes the second membranes can extend from arcade to arcade, like in this case, the vertical scan. So this is a one-eyed patient who already has a very bad TRD in the other eye. So you had a decent vision, but suddenly started losing vision of superior TRD, which is slowly migrating towards the fovea. And then he has a small cyst at the fovea also. You can see that what the transparent second membrane coming off now. Initially, once you cut the PVD, I started realizing that something is underneath. It's a very transparent membrane. And as you release from the disc, you can see that the adhesion is much more stronger as you cross over to the superior arcade. So because the one-eyed patient, I didn't want to inject oil, because the superior TRD will settle towards the fovea. Right now, the fovea is not involved. It's just threatening the fovea. But we put oil or gas, the TRD fluid is going to move into the fovea, causing long-term drop in vision. So I'm switching to a chandelier system. So I don't usually fancy this chandelier, but in this case, I felt it was very needed to prevent iatrogenic retinotomy because the superior membranes are very tight. So using the forceps and scissors, I was able to peel the membranes without creating a iatrogenic retinotomy. So you can see that that's the area which is just above the fovea, which are large foveal cysts on OCT. So now as it comes off, you can see that is the second membrane which is lying underneath that. And what I'm holding is the top layer. So this is again a very chronic TRD, again one-eyed patient. Here, as you can see, most of the times you will not need to switch over to bimanual technique. Again, you can see the use of scissors, because when the retina is very pulled up very anteriorly and membranes are very adherent, using cutters is going to be very difficult to cleave these membranes and peel the membranes from the retina. So I'm using a cutter and scissors interchangeably. Wherever I feel there's a stronger adhesion, I switch to scissors to create a division of the membrane from the retina, and then use the cutter to peel. Sometimes, occasionally, I use my light pipe to create a small bimanual traction to separate membranes. So this will help to, wherever tight membranes are there, you can use the left hand to slightly use it like a bimanual instrument. So in this case, we're able to finish the surgery without using any chandelier lights. And we also finished without creating any iatrogenic retinotomies also. So one thing to keep in mind is that when you move nasally, the vessels are much more crowded here, and the gap between the membrane adhesions is much more shorter and smaller here. So you have to be a little bit more careful and patient when you're moving in the nasal field if you want to remove everything without creating iatrogenic retinotomies. So again, as I told you, scissors is a very important instrument when you're trying to address these complex RDs. So for all young people who are listening, always don't hesitate to use scissors whenever you feel the membranes are much more adherent or the retina is much more atrophic and thin. So in this case, I decided to fill in oil because it's a one-eyed patient and he had a chronic renal failure and felt that the risk of postoperative bleeding was severe, and he was a phakic patient also. So I went on to fill oil in this case. So that's about, I wanted to talk about managing TRDs. I think over to you, Anand.
Thank you, Sarvan. And again, a huge, wonderful spectrum of different surgeries and different techniques. I mean, there's no one way to skin a cat, like they say. So it's good to see different techniques. And surgery is not like medical retina. You know, what works best in one's hand is best for that surgeon and for that patient being attended by that surgeon. I just wanted to know that, you know, you showed, bimanual vitrectomy also. Do you, when you look at a patient, do you decide that you will go in directly with bimanual vitrectomy, or would you resort to it after you feel you're not been, you know, fairly successful with unimanual vitrectomy? And I'd like Dr. Steve Charles also to after respond to that.
I don't use bimanual very commonly, very unusually I use it, and I usually don't go in directly. Most of the times I decided on table whenever I am encountering a severe problem where the retina is very mobile, or I have created a iatrogenic retinotomy and what was a TRD is now converting to a RED-RD, or when the patient has got a combined mechanism RD and the retina is already flappy and mobile with severe adhesions. In those cases, I prefer to use bimanual, and most of the times it's not at the start of surgery. Usually I decide to use it when I encounter a more difficult situation when I'm inside the eye. So it's usually during the surgery rather than at the start of the surgery.
What about, Dr. Sarvanan, a situation where you have a bad looking TRD and it's the patient's only eye and visual acuity is already quite good? Say it's the only eye, the visual acuity, macula is threatened and partially lifted, vision is about 618 or 624. These are the situations I personally choose to go in with bimanual right from the beginning. I would like your view, Dr. Charles, and everybody on the panel on that.
The thing is, each person has their own preference on how to manage a case. The last case was much more tougher than this penultimate case I showed. There I finished the surgery with only one single unimanual surgery. Decide to use bimanual when I encounter a very significant issue intraoperatively during the surgery, especially when the membranes are very adherent or when the retina is mobile, or very unusual cases like the previous case, penultimate case I showed, where I didn't want to create iatrogenic retinotomy because the tractional detachment was just above the fovea, and putting a tamponade usually pushes the fluid into the fovea, creating a long-term drop-in machine. So these are some of the unusual cases which I use bimanual, and I'm not a common user of bimanual surgery.
And your preferred gauge is?
Mine is 25.
So, Dr. Charles?
I had a question. I mean, nice, as usual, very good videos. I saw you peeling the polyp from the disc, removing it off midway through the surgery itself. Do you think? I mean, somehow I do it as the last, the last step. Surgery. Sometimes bleeding is quite significant.
Yeah, suppose if I feel that it is going to create very risky to peel that membrane, sometimes I leave it also.
Yeah.
Sometimes if I feel it's very risky, I try to peel it at the last minute. But most of the cases, once you are in the sub-second membrane plane, you see that you can peel these membranes quite easily and safely without, creating iatrogenic rupture of vessels or iatrogenic retinotomies. Most of the times it's easy to peel, but occasionally when you feel it is critical or difficult, you may want to leave it up as the last step, as you mentioned.
Great.
I would like to compliment you on your lecture and your videos, and particularly on your use of scissors and your constant emphasis on not creating iatrogenic retinal breaks. I don't have a problem with bimanual. It's used in the way you described. I like the notion of starting at the disc in order to determine the surgical dissection plane. I just pushed back on silicone oil. I had an associate that, quite honestly, I fired a year and a half ago, and every diabetic traction attachment, he aggressively peeled and made a PVD, made numerous retinal breaks, thought it was normal to do that because it was quote unquote complex, and then put in oil. And I can't remember the last one of those patients that can see because the oil has a very low oxygen extraction ratio. So do everything you can to avoid oil in these cases.
Great presentation, Saravanan. I have just one last question before we move on to the next presenter. This question is for Dr. Mahesh Shanmugam. It's not related to the video which Saravanan has showed, but there can be some complex detachments where you suspect a combined retinal detachment, but you're not able to see the break. And I know Dr. Mahesh Shanmugam was one of the first to use subretinal dye injection to find out any breaks which are not easily visible. So Dr. MPS, do you routinely use in cases where you're not able to see any break related to TRD or PVR, or are there any specific indications where you would use that?
Thanks, Raja. I wouldn't be using BBG in all cases, particularly in combined retinal detachments. I would not be using them. If it is a PVR case where I have peeled all the membranes and I'm not able to see where the primary break is, in that situation, instead of creating a retinectomy or doing an extensive unnecessary laser photocoagulation, in that situation, I inject a subretinal dye that would trans clearly, not through the retina, and then put a bubble of oil to bubble of perfluorocarbon to see where the dye is coming out from. So in very select situations I use, and not in all CRDs. CRDs, I really don't use the BBG at all.
Thank you very much. We'll now move on to the next presentation by Dr. Sangeet Mittal, who's a very, very renowned surgeon and great innovator trained from Shankar Nethralaya, and has also worked extensively for the VRSI. And he will be talking about submacular hemorrhagic detachments. Over to you, Dr. Sangeet Mittal.
Thank you, Dr. Raja. I think the video is with Sai only, and the narration is inside the video only. So I think I just. So Sai, if you can put the audio also on.
I can't hear the audio, Sai. If you can pause and just
restart Sai with the volume full.
66-year male who had undergone multiple intravitreal injections of Avastin presented with persistent submacular hemorrhage. 27-gauge vitrectomy was done without base excision. Internal limiting membrane was peeled using ICG dye. .40-gauge microcannula was used to inject TPA into subretinal space. TPA is used in the concentration of 12.5 micrograms in 0.1 ml solution. TPA is injected till it covers whole of the submacular hemorrhage and reaches beyond the temporal arcades. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. Visual acuity improved to 6/36 after 2 weeks and to 6/24 after 4 weeks of surgery. The most common complication seen with this procedure is a macular blowout resulting in a macular hole. This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of a 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 milliliter syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the VRSI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. 42-year female presented with macroaneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27-gauge vitrectomy was done without base excision. PVT was induced with the help of triancine alone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. Gauge microcannula connected to the subretinal injector was used to inject TPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6/12 at 4 weeks post-op. These are a few more cases of submacular hemorrhage treated with the same technique. An 85-year-old male presented with hyphema, dense vitreous hemorrhage and total retinal detachment with subretinal hemorrhage. To begin, the infusion was placed in the anterior chamber to drain out hyphema. Anterior vitreous was removed and it was made sure that the infusion cannula was in vitreous cavity. Vitrectomy with base excision was done. Special care is taken while removing vitreous in these cases as it is hard to differentiate it from underlying detached retina. Total retinal detachment with massive subretinal hemorrhage was seen once the vitreous opacities were cleared. Endodiathermy was done in the temporal peripheral retina in order to perform a large drainage retinectomy. Initially, the bulk of subretinal blood was aspirated through a small retinotomy using a brush needle. This prevents overspill of blood in the vitreous cavity, thus obscuring the view. Retinectomy is then extended and the retina is flipped to reveal the subretinal space. Remaining subretinal blood is then removed slowly using backflash needle. Large clots are removed using vitreous cutter. One needs to be patient and remove as much blood as possible. This may sometimes take a lot of time and multiple attempts are needed for complete removal. Once sufficient amount of blood is removed, then retina is flattened using perfluorocarbon liquid. Anterior blood clots and the peripheral retina can be excised at this stage. The fold on the retina was straightened using a soft tip backflash. Endolaser was done around retinal breaks and a 360-degree barrage laser was done to peripheral retina. A direct TFCL silicone oil exchange was performed. 65-year-old female presented 12 days after cataract surgery with vitreous hemorrhage, retinal detachment, subretinal hemorrhage, suprachoroidal hemorrhage, and a possible needle perforation. Vitreous hemorrhage was cleared. Below the hemorrhage, massive choroids were present. 26-gauge IV cannula was inserted in suprachoroidal space at the point of highest elevation. Once the cannula is in the right space, the metallic stylet is withdrawn and the plastic cannula is left to drain the suprachoroidal fluid. After flattening the choroidals, a large retinectomy was done to drain subretinal fluid. First, the brush needle was introduced in the subretinal space through a small opening to drain the bulk of subretinal blood. This prevents the overspill of blood in the vitreous cavity. A chandelier light was inserted and PFCL was used to flatten the retina. This was followed by 360 degrees endolaser barrage and silicone oil injection. Months post-operative, the retina was attached and the best corrected visual acuity had improved to 6/24. The patient is advised removal of silicone oil.
Excellent videos, Dr. Sangeet Mittal. I think great innovation on that subretinal injection. I saw that you were using ICG for staining the ILM. When was the last time you used ICG? Do you routinely use it for ILM staining now?
Not routinely, but intermittently. I do use it when the view is not very good. So in that cases, I generally do use ICG.
Very nice. Very nice.
Yeah.
Yeah. So I had a question. You showed a few cases where there was a macular hole which developed at the time of injection of subretinal TPA. Now,
Yes.
what would be your take on preventing that? Would not peeling the ILM before the ICG injection, would that have any effect on macular hole? Or how far away from the fovea would you inject in these cases?
I can't say exactly because I started peeling the ILM in all these cases just because of this complication. It was very common and it was very difficult to peel the ILM once you have injected the TPA or subretinal air. So I started peeling in all cases before I start the injection. I used to see this complication even before I used to do ILM peeling in these cases.
Great video, Sangeet. I just want to know, do you have any tips or any methods that you use to avoid choroidal injury when you put an insert that suprachoroidal injector? And I'd like Dr. Charles's comment on that technique also. Very interesting technique and very innovative.
So first is when you drain the choroids using the 26 gauge intravenous catheter, and once you enter the choroidal space, it's just a tactile response that you get that you are entering a space, and you'd have to first choose the area of the highest elevation, one thing, and then you enter in the space. And once you have entered that space, just stop at that moment, just go inside and have a look whether you are in the right space or in the wrong space. And once you are sure, then you withdraw the stillet, and then you can see that the fluid will come out. You can even connect this intravenous catheter to your extrusion pump, and you can even control the speed of the drainage, which you can be doing.
Dr. Charles, what would be your comment on that interesting technique?
For expulsive hemorrhages, large suprachoroidal hemorrhages, I don't believe that appositional, so-called kissing choroidals are an indication for surgery. I tend to watch suprachoroidal hemorrhages, and then when they begin to absorb, the vitreous will get stuck anteriorly and elevate the equatorial retina. That's when I intervene, and as opposed to acutely, as if there's somehow the retina is going to stick to retina. But when I do intervene, I use our regular trocar cannulas. I use either a 23 or a 25, and I insert, as he said, at the highest place, but at an angle. And then, of course, when you've taken the trocar out, as the blood, but I have not injected in that space. I've only allowed the fluid to come out. And I used to do it with my direct needle drainage method I invented for draining subretinal fluid in sclerobuccal settings. But then I switched over to the trocar cannula method, and I've been happy with that. With the trocar cannula method, I don't mind putting one nasally, and then if the temporal blood won't flow over there, I'll put another one temporally. So that method works, but you got to put them in obliquely so that the tip of it doesn't end up contacting retina as the choroidal hemorrhage goes away. Often suprachoroidal hemorrhages will come out around your regular trocar cannulas at the pars plana, not through them, but around them, because the blood extends anteriorly to the pars plana.
Any other comments by any of the panel? There's another question related to diabetic vitrectomies for Dr. Charles about the use of preoperative anti-VEGF injections. Do you also look to doing it days
I
before?
use pre-op anti-VEGF compounds and within 1 week, but not beyond a week. I have thought since my good friend Harry Flynn published the paper on crunch syndrome that was massively an overrated problem, and it created, oh my God, you can't inject anti-VEGF, you'll get crunch syndrome. Everybody talked about it, because Harry Flynn is such an important and reasonable guy, an honest guy. That said, I think he was wrong. And those eyes that have florid neovascularization, if you don't inject, they'll go blind from retrolenticular neovascularization or anterior hyaloidal, whatever you want to call it. They'll go blind from neovascular glaucoma. So you just switch what they go blind from if you don't use the anti-VEGF compound. But if you inject and then operate within a week, you're fine. But you must re-inject the anti-VEGF at the end of the vitrectomy. So I always put Avastin in. If they needed it before, they need it afterwards because you've taken it all out. And if you do phaco, for example, let's say somebody's needing monthly, this is off the subject, but I'll just mention briefly. Let's say somebody needs monthly anti-VEGF injections. When should you do the phaco? Halfway between the two injections. If you inject on Monday and Tuesday, you do cataract surgery. If the patient gets HRV or endophthalmitis or sterile inflammation, you don't know what caused it, and you can't get to the bottom of the problem. And if you inject on Monday and do phaco on Tuesday, the IA and phaco wash all the anti-VEGF compounds out.
Thank you, sir. That was another question about injecting anti-VEGF after surgery. So you've kind of answered that. So thank you. We'll move on to the next speaker, Dr. Mahesh Shanmugam, another renowned retina specialist in India, who's the head of retina services at Shankara Hospitals in Bangalore. And he has the unique distinction of holding a PhD in retinoblastoma management. And he's going to talk to us on management of ocular tumor-associated detachments, something which he has a vast experience and more than anybody else in the country. Thank you. Dr. Mahesh Shanmugam.
Thank you, Anand. Thank you, VRSI, for this opportunity. Can I have my video? I am probably the oldest samurai. So let's look at some of the simple techniques following the wonderful surgeries by Dr. Steve Charles and Sangeet. And there are 3 types of detachment which you can see into tumors. One is exudative detachment. I use a simple technique of exudative detachment drainage like this. So it's a 30 gauge needle with which I inject, go in between the folds, and there's a transconjunctival drainage. You see one needle in the inferior temporal quadrant, which is a 26 gauge needle connected to an open syringe. So inject, and the fluid in the subretinal space is drained with the needle in the inferior temporal quadrant, and this is a transconjunctival drainage. And the patient had some amount of subretinal hemorrhage also. That is why you see it in the subretinal space. And this is a kind of blind technique, but you can do it as a visualization technique in this video. Here, this is a retinal hemangioma, an exophatic retinal hemangioma with the exudative retinal detachment and a wide-angle viewing system. You can see the needle in the subretinal space. Instead of doing a retinotomy to drain, so transclearly I have entered the subretinal space. The bevel of the needle is facing the retinal pigment epithelium, and the infusion in the vitreous cavity drains the subretinal fluid and reattaches the retina, avoiding a retinectomy or a retinotomy in these situations. The patient also had some amount of ascites because of the retinal hemangioma, and this is the retinal hemangioma, which is peripapillary location, which is being treated with laser photocoagulation. Traction retinal detachment is often common with vascular retinal tumors, and this is a post-treated retinal hemangioma. You can see a rigorous retinal hemangioma. A lot of fibrous tissue can form in the area where it has been treated with cryo, and we need to be very careful in these areas not to create a retinal break. There is a posterior extension of the fibrous tissue, which is being gently peeled. You can see the dilated vessels which are leading on to the hemangioma. And this cannot be peeled off. We just peel it up to the strong attachment to the tumor and dissect it very, very carefully, taking care not to create a retinal break. I used to very rarely resect these tumors, but now I found that it's not a good idea to resect them, leave them alone and support under the pre and post-treatment, post-vitrectomy appearance. And this is a cavernous hemangioma. Usually we leave them alone, and this is a child which had traction macular detachment. That's the macula which is lifted up like a knife. And this is the peripapillary cavernous hemangioma with a lot of fibrous tissue. Obviously, we cannot remove these tumors, but this fibrous tissue can be circumcised and left around the tumor, limiting it and decreasing the amount of traction on the fovea. Obviously, the visual recovery is going to be poor, but then some amount of visual improvement did happen in this child. So that's at the end of the surgery, and this is post-treatment. Some amount of reattachment of the macula has happened. Rarely we come across regmatous retinal detachments. Once again, in angiomatous retinae, I stopped doing cryo for large tumors such as these. I treat them with brachytherapy, and you can see regression post-brachytherapy. And this kid was doing well for about a year, and subsequently he developed regmatous retinal detachment. You can see large amount of subretinal fluid, subretinal exudates, induced the PVD, perfluorocarbon, to stabilize the posterior pole, peripheral vitrectomy. And you can see the vitreous looks sick because of the amount of exudation. And this is the nasal tumor. Earlier, we used to resect them, but I stopped resecting them because resecting results in a large amount of fibrosis and resulting in phthisis of the eye. So this is the treatment of the feeder vessels to that area and replacement of silicone oil. And I support these periphery with a buckle. This is a 42 band supporting the peripheral fibrous tissue. And this is the modification of the solid silicone, which is placed under the area of the tumor to support it as well. So using this technique of brachytherapy and a peripheral buckle along with the vitrectomy, I find the risk of losing these eyes is much lesser, and there's a post-operative appearance. Moving on to retinoblastoma, regmatous retinal detachment. Earlier, we used to be very, very scared to have intervene in these eyes until we are sure that the tumor is inactive. But currently, we use chemotherapeutic agents in the infusion and go ahead with vitrectomy very, very carefully. So here again, we have placed a pre-placed buckle. So take precautions not to spill the fluid from the vitreous into the orbit. And as I mentioned, there is melphalan or topotecan in the infusion fluid. This is the only eye of the child with retinal detachment and PVR and partly treated retinoblastoma. Some of the tumor is still active. What is interesting is look at the vitreoretinal adhesion. It's attached around the tumor and had PVR as well. The PVR is also removed. And this is the area where the prior surgeon had done cryotherapy to the tumor. And that's exactly where the break was. And the retina was contracted and the vitreous was strongly attached. So retinectomy had to be done in this area. And this is the posterior tumor. I was wondering whether to remove it, but obviously it's not possible because it is sticking right over the macula and attached to the disc. So I decided to leave that tumor alone. And the retina is reattached and laser photocoagulation is done and silicone oil is used for tamponade. And in addition to having a chemotherapeutic agent in the vitreous cavity, distilled water is cytotoxic to retinoblastoma cells. So I balloon up the subtenon space and the subcaninical space with distilled water. This tends to kill cells. And this is a very, very difficult situation child, one-eyed child. And I had treated this child. And what you see is the tumor over the disc extending along the arcades. So we can't see where the disc is. You can see the PVD is being induced over the macular region. And this child had already had one retinal detachment. I treated it with a scleral buckle, but subsequently developed another break somewhere. So reattached it by doing a vitrectomy. But then what happened was the superior temporal arcade tumor, where I'm doing laser now, that is lifted up. And that kept the retina lifted up and the break lifted up. So I tried doing a macular buckle, it failed. And subsequently, I had to go back and literally cut this calcification away from the main tumor. This calcification extends into the macula, so I cannot do a retinectomy all around because it will go within the arcade and also close to the disc. So I very gently cut this calcification. So this disc calcification, which is tending up the retina, will fall back and allow reattachment of the retina. Unfortunately, we managed to keep this retina attached over the last 6 or 7 years, and the child continues to see with this only eye. So that the fluid gas exchange, that's exactly where the break is. As I mentioned, that part of the calcium was lifting up, tenting up the retina, not allowing it to reattach. So I had to cut the calcium, allow it to reattach, but at the same time, not create a retinal break. Thank you very much.
That was amazing. Could I comment just briefly?
Please do, sir.
David Abramson at Sloan Kettering in New York has manages many retinal blastomas and sends me cases that have persistent subretinal fluid, which seems to be exudative, overlying a calcified, presumably inactive retinal blastoma. And so what I've done with them, because I am afraid to cut on the sclera, I don't do buckles. I recognize that you have a lot of expertise and that a buckle has worked well in your hands, but I haven't buckled any of that. What I've done is pick the quadrant of the pars plana that's farthest away from the tumor and made all 3 incisions side by side, infusion and illuminator. So you have to hold your hands in a strange way like this or like that, but I've been on, and I've actually held the endoluminator and the cutter in the same hand with different fingers in order, let's say it's an infranasal big retinal blastoma that's now calcified. I'll make all 3 incisions in the supratemporal quadrant, do a vitrectomy, stay well away from the tumor, and then well away from the tumor, put air and do fluid air and make a drainage retinotomy, and immediately with the cutter drain the subretinal fluid out so it can't spread. And then I laser in a contiguous way, confluent laser around that retinotomy, put in oil and leave it. And I've done I think 13, and one of them the retina was so rigid it wouldn't reattach. One of them, well, 2, I couldn't reattach it, but the other 11 are doing well, and some of them are as many as 8 years, 9 years out. So that's a nice way where you're not you don't worry about providing a pathway for tumor to come out of the eye through your incisions.
Yeah, thank you, Professor Charles, for the tip. Yes, I used to do these limited vitrectomies as well, but then currently with the chemotherapeutic agents, it's become a little bit safer. And in addition, I follow it up with post-operative chemotherapy as well as radiation, if in case this is the only eye of these patients. Thank you.
I was fascinated with your intravitreal chemo. I was not aware.
Thank you.
Great videos, Dr. Mahesh. I just had a question. When have you ever had, or is there any risk of tumor seeding or reactivation? Have you had any such experience? And do you tend to cover it up with post-operative chemotherapy additionally?
Yes, like usually you prefer to wait until the tumor is quiescent before we intervene, but like these are select situations where there is the only eye and the child's eye will be lost if you don't intervene. We do chemotherapeutic agents in the vitreous cavity, in the infusion fluid, preoperative chemotherapy, postoperative chemotherapy, and in select situations, I would do a whole orbit radiation. So this also kills all the cells. As I mentioned, we use distilled water very liberally. Distilled water kills the retinoblastoma cells. So even with an intravitreal injection of melphalan, I use distilled water in the subconjunctival space and create a lake of distilled water over the eye, leave it for about 3 minutes for the spilled cells to die. Otherwise, as I mentioned, prefer to wait until we are very sure that tumor is inactive. But like this fear of intervening in an eye with retinoblastoma, we are losing it a little bit gently because there is one publication from China where they have done vitrectomy as a treatment for recalcitrant retinoblastomas. I wouldn't go so far to do that, but then in select situations like retinal detachments and only eyes, yes, we are intervening a little bit early nowadays.
Mahesh, one small question. In your first video, you use the 30-gauge needle to go inside.
Yes.
But sometimes when you have this bullous detachment in a phakic eye, I mean, what's the trick? How do you enter? I mean, it's very difficult because you find the detachment is more or less reaching the posterior surface of the lens.
Yes, I agree. So what I do is like tilt the eye and gently depress it. So you'll be able to see that indentation inside when you tilt the eye. And in between the 2 folds, you go gently and inject a little bit so that the retina sometimes is attached to the lens, in particular in Coats disease. Then create a fluid pocket, then it becomes easier. But in select situations, even that may not be possible, in which case I inject into the anterior chamber very, very gently and push the retina a little bit back, and then go in between the folds with the 30-gauge needle, inject a little bit, create a pocket, then put the 26-gauge needle to start draining. So that's what I agree. It's a little bit tricky, but you can get away with it if you're going in between the folds and depress and roll the eye so you can see the indentation and then inject inside.
The 26-gauge needle you put in the infratemporal.
Infratemporal with the bevel facing towards the sclera and with the plunger removed. Yes, with this technique, you are not too sure if you are able to drain the fluid completely, but like the risk of creating retinal break is extremely low because it's kind of hugging the RPE. And these are eyes where I am not keen on having the retina completely attached. For instance, the Port's disease, where following this, once the retina goes back, inject a steroid into the vitreous cavity and do laser photocoagulation. Or in this patient where there was a hemangioma, we drained it and then laser photocoagulation. So it's not necessary to completely drain it because the pharmacotherapy takes over subsequently.
Yes, Dr. Bende.
Let me mention a brief comment. I first reported needle drainage of subretinal fluid for the diabetic traction, for the rheumatoids in the retinal detachment setting with a buckle. But I thought it was fascinating that you've used it in these exudative angioma-related detachments, which I've not done. So I learned that from you. If you do a vitrectomy, and in my case, the fellow put the infusion cannula in the suprachoroidal space, and now you've blown up the choroid. A very effective way to get that fluid back out is to do the needle drainage method, and you enter very tangentially, obviously where the choroidal is the highest, and you could do it as he did in his video, transconjunctivally. So it's also a way of rectifying an inadvertent suprachoroidal infusion.
Yeah, thank you.
Yeah, Mahesh, you mentioned distilled water in a subconjunctival to inject the subconjunctival. You know, it's a very corrosive. Do you have any inflammation, chemosis, early post-operative period?
Not really. I was used to think that distilled water is bad to the eye, but then like even for the retina, but intravitreal injections of distilled water, like we mix with antibiotics for endophthalmitis, and then I have done a literature search where they found that like distilled water is not really bad for the retina also, because sometimes when I do this vitrectomy, I leave distilled water for about 3 minutes inside the eye and then remove it and replace with BSS. That also I do. But I have not had any severe inflammation or severe reaction in the subconjunctival space post-injection of distilled water.
Oh, yeah, that's what I wanted to know. That's fine.
I think
you get distilled water in your eye every time you swim.
Yeah, but I think distilled water putting on the cornea has become white. I think once instead of finger lactate, I think the assistant used the distilled water, and cornea became white and couldn't see, and I think it becomes a total corneal edema. So I think you have to keep that in mind.
Only at the end of the surgery.
There's a question from Dr. Jalali about what is the dose of chemotherapeutic drug used in the infusion fluid, if and when you choose to do so, and what is the metastatic risk, both local and distant?
The risk has not been proven to be high. As I mentioned, these are things which we are doing in rare situations. So I have not had any patient who has developed a recurrent tumor outside the eye or as a distant metastasis. So we have a way of mixing the melphalan as well as topotecan. I will share with Dr. Jalali individually.
Sure, fantastic. So Raja, I think we can move on.
Thank you.
So it's now my pleasure to invite Dr. Padmaja, Senior Consultant at LV Prasad Eye Institute, Hyderabad, and she deals with a lot of inflammatory case and assorted case. And it's a pleasure to introduce our only lady samurai of the day. We're very pleased to have her here. So Padmaja, let's see, she's got an amazing spectrum of cases. Please go ahead. I think you're muted.
Can I play?
Sai, please go ahead.
Go ahead. Should I pause the video, madam?
Sai, we are not seeing the video.
We can't see the video or hear any audio. Able to see now, doctor?
Yes, yes.
Is there any audio? We can't hear the audio.
No, Padmaja will be narrating.
So Padmaja, we can't hear you. Padmaja, can you hear us?
I think we'll probably go to the next presentation and come back to Padmaja because she seems to have some issue with the audio.
Okay, doctor.
Anand, I think Anand, you can probably have next presentation.
Parijat's presentation, Anand, then come back. So she's fixing it.
Can I start sharing, doctor?
Yeah, please start. Can you hear my voice?
Yes, very clear.
Yeah, please start. Yeah. Okay, so I'm going to be presenting a set of 4 cases. So this is the first case. So this is a case of aggressive posterior ROP which developed stage 4A. Here what you see, we're doing a 25G vitrectomy. The traction is being removed from on top of the retina, which is already lifted. And now you see here are the fresh laser marks which have been given just prior to surgery with an LIO. And the entire vitreous is being removed. And now you see the yellow glow of that vitreous is gone. And now you see the pink retina is there. And the PVD is being done here. You see the macula is not properly vascularized as yet. But this is how the entire traction is relieved. The laser is done. And now this is what it looks like under air. And this is how it looks like post-operatively at 4 weeks. You can see that the entire TRD has reduced, although some remnants are there. And the laser marks are there. And so the outcomes in stage 4 ROP are really good, even in such advanced cases like this. So let's see the next case. Can you put the second case? Okay, so this is the second case. This was the case of stage 4 ROP. As you can see, there are a lot of fibrovascular proliferation till behind the lens as well. So this is a 25 gauge vitrectomy again is being done. And if you see, a lot of this tissue is stuck behind the lens. And below that is the stage 4 traction which is there. So now diathermy of these vessels is being done. Sometimes a big vessel can be there which can breed. And once you do that, all this tissue can be just cut away with a cutter after you diathermize it. You have to be very careful behind the lens. Some remnants might be there. Lens injury has to be absolutely avoided. And there you can see, again, this is at 4 weeks. You can see that the entire TRD has settled down and the macula looks okay. Although in the top right, if you see, there are some remnants of the lens attachment. Next, please. So this is the third case. This was again a case of APROP. This case had resolving vitreous hemorrhage. He has already been injected earlier by someone else. You can see fresh laser marks have been given. The vitreous is densely adherent to the retina and suction is being applied to remove the attached adherent vitreous. After that, this blood is being removed with the back flush. It's all being flushed out. And once all that is removed, then you can see the retina will be there and it's all puckered in the center. So after all that is removed, so this is the last bit of tissue which is being removed, but if it doesn't come easily, then it's better to leave it. Otherwise, you can end up with a nitrogenic tear. And here physically with the cutter, the retina is being spread apart and settled. So this is how it appears at 4 weeks. Again, you can see the entire pucker has gone away and the retina has regressed well with removal of the pucker and the resolution of the disease. Next, please. So the next case is a stage 5 ROP. This is a technique which I like to do. It's known as a hybrid clear coordinate technique, which we published. So this is a 23 gauge MVR which goes in, and through that 25G instruments will go in. So there's 25G infusion cannula going through 23G MVR opening. So this, I believe, provides a very snug fit of these instruments without much fluid leakage, and later also allows sutureless closure. So the lensectomy has been done, and now this dense retrolental membrane is there. And so this is being cut with an MVR so that excess is allowed into the lenticular space. And once you remove that membrane, you can see here bimanually an attempt is being made to increase the size, and then the cutter can go ahead and increase the size of this opening so that you have an adequate space to go inside. And now you can see the contact lens has come in and the remnant tissue is being removed. So as we continue to open the funnel, you can see this is the last bit of tissue which is coming out, and there you can see the disc will be there. There is the disc, and there is the posterior pole which is almost attached. And at the end, you can just go ahead and hydrate these incisions because they are 23 gauge incisions. And once the wounds are hydrated, you can inject air in the AC, and mostly no suture is required because these are small incisions. They have been hydrated, as well as intralenticular, the air is there in the anterior chamber. So these wounds usually hold and sutures are not required. So I believe to attempt surgery in many of these stage 5 ROP cases, because not that the results are very good, but it does help to provide navigable vision in a large number of cases where usually open funnels are there. Thank you.
Yeah, terrific surgeries. Parijat does a huge amount of ROP surgery at the All India Institute of Medical Sciences, and takes care of a lot of ROP there. So it's amazing. Thank you. And one question I had is about, retinotomies and are almost like a game closer in ROP surgery, unlike other surgeries. So when you face that, what is your go-to protocol? Do you kind of stop, or have you done anything to tackle them? That's one. Second thing is resurgeries with ROP. Is there any situation where you would go ahead and do those, and your protocols there?
Can you repeat the first question, please? I didn't get it.
You have a retinotomy.
Okay.
Almost always a game closer. But do you do anything, and your take on
in stage 4, stage 5?
Yeah, stage 4 or 5.
Okay. So firstly, we have to avoid breaks in most of these cases, because if you end up with a break, then the problem is a different ball game altogether. The case totally changes. As Dr. Charles said, oil and all just makes the game very difficult. So this has to be actually avoided. But however, if an attached retinotomy does happen, then usually I just laser around it. Don't do too much PVD around that area. Don't try to remove vitreous over that localized area, and I continue with my surgery. If a break happens in a peripheral area where the retina is detached and it's a small break, then again I don't fiddle too much of that area, and mostly it stays as it is, although traction later can increase the size of that break. In a case of stage 5 ROP, earlier I used to abandon these cases, but now I no longer abandon these cases. There's a high chance of breaks happening in stage 5 ROP, because as you are dissecting membranes, pulling membranes, doing bimanual dissection, there is a chance breaks might happen. But if they happen, they're anyway in a detached retina, and anyway you're not going to put oil, you're not going to do air fluid exchange, you don't want to settle these retinas, they will not settle. So I do continue performing surgery in these cases, even if a break happens in that particular area, and I don't abandon the case.
Okay. Dr. Pramod Bende, another very prolific ROP surgeon. Any pearls on this?
Yeah, partly I agree with Dr. Parijat says. Previously, that's what you rightly mentioned, dictum was once you have created break, case is lost. And with the experience, we realize quite a few of these cases, you can still settle the retina. What I do is probably just ensure that try to relieve as much traction as possible. And quite a few cases, you can relieve traction in these eyes. When the retina is attached, or when you are not created initially break, you want to be conservative. But once you have created break, and otherwise you leave it like that, anyway case is lost. Then we become much more aggressive. Quite some time I do bimanual dissection, and I think we could settle quite a few retinas, and we have a publication also like with the intraoperative breaks, and then after that settling the retina. And I think I could got a best corrected visual acuity. One of this patient we could achieve almost 618, and there are a few. Yes, so it's not anymore that you just give up. Yes, lot of patience, lot of time you need, but you can settle few of them, not every case. But.
Any practical pearls on that, Dr. Charles? ROP surgery.
Oil is bad news. Breaks are bad news. The open funnels are the ones where you can get success. Closed funnels, the visual outcomes and the recurrence rates are miserable. In a sense, if most of the cases, if retina's right up behind the lens, I've done 1,100 of those eyes. I published in the peer-reviewed literature, and the visual outcomes are absolutely miserable in the 1/3 that remain attached. Reproliferation at the equator is really common. And the iris will become adherent to the equatorial retina. If I take the lens, I take the capsule to prevent that ring Schwela proliferation in the periphery. But in short, try not to do 5 narrow funnels, closed funnels, because you're going to lose. And try as hard as you can not to make a retinal break, because the prognosis is much worse.
Thank you, Dr. Charles, and thank you, Dr. Parijat. There's a slight change in sequence. We will go ahead with Dr. Naresh Yadav first. Dr. Naresh Yadav, as we all know, he is the chief of Retina at Narayan Netra, Bangalore, an excellent surgeon. And
Raja, we have Dr. Naresh Babu here.
Not Naresh Yadav.
Arvind Madurai is the head of Arvind Madurai.
Yes. Sorry, I'm extremely sorry. I'm extremely sorry about that. So Dr. Naresh Babu is an excellent surgeon from Arvind Madurai, and he has shown excellent, fantastic videos all through these years, and he'll be talking about FEVR and retinoschisis related retinal detachments. Over to you, Dr. Naresh Babu.
Sai, can you play the video? And when I say go to 6, can I have?
Can you hear me?
Yeah, we can hear you.
So Dr. Naresh is presenting now.
Can I play the video, doctor?
Anand?
Yeah, you can go ahead.
Yes. Yes, sir. The first lock.
Yeah.
Yeah, please go ahead.
You're able to see the video?
Yes, we can see the video. Yes. Is there any audio? I can't hear any audio.
There's no audio.
Naresh, we're not hearing you.
Dr. Naresh, are you muted?
Sir, I am unmuted. I think wrong with the...
I think your connection is low. We're not.
Yeah, your audio is breaking up.
Oh, connection is very low.
Also.
Okay, some wrong with the...
I have a feeling your net connection is weak.
I think it's the COVID effect in Madurai.
Possible.
We couldn't hear Padmaja either. Maybe. So I don't know, Anand. So how do we want to go about this? Do we want to go back to Padmaja or
have it later?
Yeah, I think we'll. If Rajiv,
you can go.
We'll go with Rajiv right now.
Oh, okay. You want to go to Rajiv? Okay.
Yeah, I think we'll sort out Naresh and Padmaja later.
Can you hear me?
Naresh, Padmaja, I can see her here. So Rajiv, are you?
Can you hear me?
Yeah, I can hear you. So Dr. Rajiv is the clinical head at LV Prasad, Hyderabad, and again a very prolific surgeon who does this endoscopic vitrectomy, very unique technique that he's kind of showed over the years, and we've learned from him. So he'll talk to us on traumatic RDs and endoscopic vitrectomy. And this is going to be quite an interesting series of videos. So can we have Dr. Rajiv's video, Sai?
The trauma, as you know, it's not a simple task. As you can see this patient where you have a lot of hemorrhage and you can see the cannula, where I used actually a 6 mm cannula and clear the vitreous in the anterior part and then try to clear so much that we'll be able to get a clearer view. So that's one thing which is important. So with here, I'm just trying to put a PFCL bubble to start settling the retina to get an idea of what's happening there all around and keep looking at areas and try to remove the vitreous all around. You can see this part where the vitreous is trying to go into the cannula. So one thing which I wanted to highlight in this is mainly this fold of retina, which is stucking at the end of the surgery. That's basically because of the incarcerated retina, which is there in that scleral wound there. So this, if you leave it there like that, it's not going to go. So that's when we need to get into cutting the retinas and doing a retinectomy. So when you do a retinectomy here, so I try to cut not just at the band and just go a little beyond it and go up till the ora. And then as Charles was talking about doing a diathermy mainly to the larger vessels, see, that's what I usually tend to do, and then try to cut that whole area and try to do a laser. And I usually do a continuous laser. I don't do multiple spots like what we were talking about. So that's go connect it to the up to the ora. So that's how you can actually manage the incarcerations. This is a next case where a blast injury, one-eyed patient, you had a multiple foreign bodies inside. So the option was to do a corneal temporary keratoprosthesis, but then we thought had an advantage of using an endoscopy. So where you can actually see those small particles which were there inside the vitreous cavities, which we could clearly see using an endoscope. This is an endoscopic view of what we can see. So that's how you can actually take out all these small, tiny foreign bodies using the endoscopic vitrectomy. So this is a foreign body stuck, which is almost at the pars plana area. So you can actually clear that vitreous around and then try to get that foreign body out. I usually use a suction to lift it up because more air dramatic and it's actually easily picks it up and then gets it out. To lift any of the foreign bodies, and it's simple and easier to do. And at the end, you can actually do fluid air exchange, and you can actually see a good view of retina even after the air exchange, and go ahead and do the laser and settle the retina. So this is a few of the simpler surgeries, and then you can still have the cornea like that. Some cases like this, where you have an extensive trauma, and we were in two minds whether to go ahead with the temporary keratoprosthesis or do surgery or not. So we thought, let us, we have an endoscope, let us look at what is happening inside. So I tried doing an endoscopy in this and looked at the retina. So what you can see is a complete folded retina with stuck at one end, and it's like a cord, like a retina. So then the question was whether to go ahead and do surgery or not. I was not sure, but then we said, let's try this. So these are all the subretinal membranes, which you can see, and keeping the retina folded up like that. So in this, we tried with the forceps, and you can see the magnified view of these membranes. So here I put a PFCL in subretinal space actually to keep the retina stable in one side when you're trying to pull it. So then I remove these membranes using the forceps and then start opening up the funnel. So once I opened, as you can see that the fluid movements would be causing all the whole retina to one side. So then we had to open the funnel and then put a PFCL inside. So now since the funnel is opened, I've started putting the PFCL inside, then opens up, and then I did a retinectomy and then started doing a laser all the edges of the retina. So that's how we could settle it. So we could manage without doing a temporary keratoprosthesis and then trying to settle the retina. So there is another case where the chisel and hammer injury, where you had foreign body inside, and they were tried seeing through my corneal surgeon said I'll be able to change the cornea because we didn't have temporary keratoprosthesis available immediately at that time. So this is the view through the endoscopy where the foreign body was stuck in the periphery and exudates. As you know, when you are going through the edematous cornea, it's not easy for you to identify any of these foreign bodies, and you can actually clearly see these foreign bodies wherever they're stuck using an endoscope, and you can clear that vitreous around it, and then release the foreign body from that area, and then clean that foreign body along, clear the attachments to that, make sure that you remove all those things before, and then try to get it out through the anterior approach, and then you can close it out. So again, you can actually attach the retina clearly, and then you can see the retinas were quite good behind. So though the infection and the cornea was too bad, so to start with, so that's how we could manage with an endoscopy without going through a temporary keratosis process and the long duration of surgeries for doing keratosis and things like that. Thank you.
Could I comment briefly on that?
Yes, go ahead, Dr. Charles.
I'm not a fan of temporary epikeratoprosthesis. If you meet if you can't see through the cornea and the patient can have general anesthesia with neuromuscular blockade and they don't have out of control hypertension, then I just simply make a PK opening myself without the corneal surgeon. I do the vitrectomy with the vitrectomy machine, open sky. I can access the subretinal space to peel membranes and these closed funnel detachments. I can take tissue easily with Van Ness scissors and Colibri forceps off the surface of the ciliary body, even off the back of the iris, so you don't end up with hypotony, and simply pour the oil in until it comes up to the iris plane, or even if there's no iris, to that level, and then put the button in and close it on an air bubble. You can't close it in viscoelastics, but you can close it on an air bubble. And I can do that in an hour in these trauma cases, and it's better than this whole step of the epikeratoprosthesis. And you now have access to the ciliary body surface in the back of the iris, and it's much easier to get in the position to remove material from the subretinal space. So it works really quite well.
Yeah, agreed. But the only concern is that like you have so many ifs there. So if the patient needs to be under general anesthesia, and then you need to have all those features. The advantage of endoscopy is that we always had used a temporary keratoprosthesis and always never been happy with that, and creates too much of an issue, especially seeing the periphery and you want to depress and it keeps opening up, leaking out. All those things can be avoided using an endoscopy. In cases where you don't have any of these options, this can be done in anyone, and you can actually
you control the intraocular pressure so nicely with endoscopic.
Yeah.
So nice cases. Thank you.
Yeah. Also to add at what Rajiv said, because invariably if you have put a silicone oil, you eventually after some time you are going to have a re-PK. Invariably all these eyes. So if you can manage without having a cornea, if you're doing PK at first go, we can have just only one PK later on probably. Particularly when places where we have a shortage of corneas, if you can complete surgery without doing PK during first sitting.
And if you do a PK in these eyes with vascularization of the peripheral cornea, then topical Avastin is crucial.
Yeah, we could actually save many PKs, actually many corneas, because we could avoid many of these. And we actually at the end of 1 month, 1.5 months, I do a diagnostic endoscopy. We'll just put a probe inside and see what's the potential, and then go ahead and whether to go ahead with an keratoplasty or not later on.
Very nice.
That's an important point, because many of these cases, while we may have done a good surgery in the first attempt, but then you see that the optic nerve is atrophic, there may not be much use doing a keratoplasty later on. So diagnostic endoscopy later on also would be very useful to use in cases where you may avoid a second PK or these cases.
So I think that's wonderful videos. Thank you, Rajiv. It's always a pleasure to see these endoscopic vitrectomies. We'll now move on to, like I said, our only lady samurai. I think Dr. Padmaja is up again. She's going to talk to us on uveal effusions, uveal detachments. And welcome, Padmaja. She is a senior consultant at M.V. Prasad Retina Department. And Sai, can we have Dr. Padmaja's videos?
Yeah, can you hear me first, Anand?
Loud and clear, loud and clear. Very nice.
Oh, yes. So thank you, Anand and VRSI for this great opportunity. So can it be full screen, the video?
Yes, it is running, Padmaja.
Okay, so it's a 36 year, I'm describing a case of 36-year-old gentleman who came with a gradual progressive painless loss of vision in both eyes, and his anterior segment examination was unremarkable, and fundus showed an X-ray to retinal detachment bullous with a prominent aura in both eyes, and axial length was actually normal, and his ultrasound showed a choroidal thickening, and peripheral angiogram did not show any leak. And with this picture in mind, he was actually diagnosed elsewhere as activated detachment and was started on oral steroids.
Padmaja, can you be louder?
He was started on oral steroids with which, can you hear much better?
Yes.
Yeah, so oral steroids, and with which he actually worsened. So then we expected that this could be an uveal type 2 type of uveal effusion syndrome with normal axial length and thick sclera, and we planned a surgical approach. So surgical approach was a 4-quadrant partial sclerectomy under anterior chamber maintained assisted subretinal fluid drainage. So I made a 360-degree peritomy and 4-quadrant partial 4 into 4 mm thickness, partial thickness scleral bed was dissected in each quadrant, and the dissected scleral bed was actually excised. And this was done in all 4 quadrants. And this after the scleral thick, one can see that the anterior chamber maintainer was kept actually in the same quadrant where I was planning to do the subretinal fluid drainage in order to prevent any inadvertent lens touch. And in the same quadrant, in the infratemporal quadrant, we made another small deep scleral tissue dissection, and with 7-0 Vicryl after making choroidal exposure, then the subretinal fluid was actually drained. And with this, the complete fluid could be drained, and this procedure was repeated in both eyes at a 1-week interval, and we could see the resolution of the exudative detachment on the table itself. And on the first post-op day, there was complete resolution of the postoperative detachment in both eyes, and autofluorescence picture actually showing characteristic leopard pattern with RP focal thickening seen under the OCT in both eyes. He is maintaining 20/25 N6 vision at 1 year follow-up without any recurrence of uveal effusion. So my next video is I'm going to have different spectrums. So this is an ocular cysticercosis case managed by actually Abhilasha Alone, our fellow, under mentorship of Divya Balakrishnan. This is a cysticercosis which was an intravitreal location. So we see actually intravitreal location of the cysticercosis almost 60% of the cases, and subretinal will be usually in 40%. And after doing PVD induction and the cyst peripheral vitreous base excision and shaving, and thorough vitrectomy was done peripherally and also around the vitreous, all the attachment. And this you can see the actually the sign of the peripheral entry of the cyst, where the possible retinal break in the periphery. And after that, a sclerotomy was actually extended with MVR blade to engage to remove the aid the removal of the cyst. And the cyst can be actually engaged with the flute needle, or can be with the cryoprobe, or can be eaten in the cutter if any rupture. Here we have used the flute needle to engage the cyst, and during process of the removal, the pressure was raised to 60 millimeters. So what happened was, while just coming out, actually at the end after coming out, the cyst got ruptured, and the scolex was actually can be seen. And this because of the toxic products actually can be eliminated by the wash of the products itself, and then endo laser was done around the possible break site, and fluid air exchange was done. So this is this patient actually maintained a good recovered a good visual acuity of 20/100 at 1 week. Then this is the third video is about a type of uveitic detachment, which is particularly that is acute retinal necrosis. The important feature here is abnormal vitreoretinal adhesion and thick cortical vitreous which will be adherent to underlying thin atrophic retina. And the important challenge here will be the peripheral, the posterior retinal breaks, which will be very thin, and also in the periphery we will be seeing actually a necrotic sieve-like retina. So this is where the importance will be in terms of, after doing a good cortical vitreous removal, one can actually use perfluorocarbon tamponade and can actually achieve good functional outcomes. In our in-house series, when we have used pre-op valsaclovir and steroids, they actually prevented retinal detachment. Retinal attachment rate was better in these cases of acute retinal necrosis. Next video. So you can observe that sieve-like retina, which will be the characteristic feature of these acute retinal necrosis detachments. This is a very interesting case which has come from our Vizag LVPI team managed by Dr. Bhavik Panchal, which is a nematode live motile large worm in the eye, which causing a diffuse unilateral subacute neuroretinitis. The patient came with disc edema, macular edema, and yellow crops in the posterior pole. And you can see the worm movement very nicely with the actually fundus camera captured with the screen. And one can actually, sometimes these patients can have cutaneous larva migrants. And this, when you see a live worm, is usually found only in 30 to 40% of cases of DUSN. And the outer retina you can see in octa, in actually a hyperreflective dot when it is worm is mobile. And the Pascal laser photocoagulation was actually done at the head end and as well as the tail end of the worm to mobilize and then do the laser barrage completely. So this resulted in mobilize and along with antihelminthic agents. So one can observe that actually around 1 week the worm was still there, but around 2 weeks, so go back. No. Yeah, at 2 weeks, actually, the worm actually completely disappeared. So, and at the end of the 6 weeks, actually, he reached. He recovered complete visual acuity. So along with the laser photocoagulation of a motile form and steroids and corticosteroids and antihelminths, this play a very important role in management of this nematode retinopathy. Next. And the last video is a peculiar situation which we can see is an endophthalmitis with retinal detachment. This is a child with a congenital glaucoma who had a actually injury and then therapeutic PK and then post and also endophthalmitis. And one can see in this endophthalmitis cases, what you see is the important problem is the medial haze, and also the perfluorocarbon here can also help in actually improving the clarity and also keeping the retina keep in place, and one can actually do a 360 degrees retinal detachment. So the media haze plays a very important role, and the thick peripheral exudates and underlying attachments in the periphery, one need to actually take care, and sometimes we have to go for this 360 degree retinectomy in these patients, especially when you are having with endophthalmitis with retinal detachment. Thank you.
Very good, very good. I think the Padmaja, I think wonderful videos. And I just want to tell in the cysticercosis, you don't have to actually extend the sclerotomy. And if you do a wound toileting, that means clear the vitreous in the vitreous base region near the sclerotomy. And then through the 20 gauge, when you made, it just comes through like a dumbbell shape. Only thing you have to do it slowly. And I usually suction part of the cutter without the cutter, and then have the suction continuously on, slowly bring it out. But good, I think all your cases were wonderful.
Yes, it was actually our whole team represented the videos actually. Thank you.
Thank you for showcasing not just your cases, but the entire department's great encouragement for the youngsters also.
Entire network.
Yes, terrific. So I think we discussed this earlier also about your uveal effusion syndrome cases, and I'd like Dr. Charles's comment on that also. So for inferior, when it's predominantly inferior, you necessarily have to do subscleral sclerectomies in all the quadrants, and do you remove the trapdoor flap all the time? Because the classic technique is to preserve that trapdoor flap and just remove the one inside, the smaller one. So your take on that?
This is for Steve Charles, right?
For you, Padmaja, and then Dr. Charles.
Yeah. So this is a case of bilateral uveal effusion syndrome with exudative retinal just behind the lens. So I have done, this is a case in this guy, both bilateral, this partial sclerectomy, why it was exposed, because he was actually became refractory to the steroids that was given earlier. So we know that there is an abnormal thick sclera definitely playing a role here. So that's why I thought by removing that sclera in all 4 quadrants, it will improve the flow. And when one eye actually responded well, and even the subretinal fluid drainage combination also is not always discussed. But these cases, usually if you don't combine with SRF drainage, these cases may take time for resolution, sometimes 2 to 3 months. So when I saw a good improvement in this case within 1 week, when he responded very well and complete resolution, I followed the same technique in the other eye. And he's having now 1 year follow-up and he's maintaining. And this anti-chamber assisted will also give you a controlled assisted drainage. And to prevent lens touch, you should put in the same quadrant as where you are training.
I agree. It's just that if it's predominantly inferior and the superior retina is attached, I usually would just do the inferior sclerectomies rather than superior. So, Dr. Charles, how would you manage these difficult cases?
I really don't have enough experience with these to comment. I haven't done a sclerectomy. I trained at Bascom Palmer where Don Gass was an advocate, and so I've certainly seen them, but I haven't seen these in my own practice at enough of a rate to really comment.
Okay. And with acute retinal ARN cases, ARN acute retinal necrosis, RDs, Dr. Charles, do you always prophylactic, if you see ARN, healed ARN, with the degenerate retina, there's always this debate about whether one should do a prophylactic laser for them. Would you comment on that?
I don't do prophylactic laser. If they detach with ARN, then I do a vitrectomy in oil, and I do no laser at all at the time. I simply use oil. So what does oil do? It's not tamponade. There is no such word as tamponade in physics. It's interfacial surface tension. To do what? What I call rhegmatogenous confinement, new breaks, or one other thing, retinopexy avoidance. So think of those 3 concepts in sequence. Interfacial surface tension management for rhegmatogenous confinement for missed breaks, new breaks, or breaks you intentionally don't treat, which I then call retinopexy avoidance. So if you have a necrotic retina, lasering it is the stupidest thing to do. I see this all the time in trauma. There's a foreign body sitting on the retinal surface, and somebody makes 3 rows of laser around it before they take it out and make the scotoma 3 times bigger. If in the same thing in ARN, if you already have retinal necrosis or you have mechanical retinopexy, as I call it in the trauma case, don't add additional retinopexy, leave it alone. After all, much of what we deal with is reactive Mueller cell gliosis, which is more like a keloid than anything else.
Yes, Dr. Pramod?
Yeah, coming to Padmaja's first case, actually the question what you asked previously, we used to do like limited 2 quadrant, like a scleral dissection and then just opening, but we realized there is a higher incidence of recurrences. So now once we are going, we all do like usually do, because all 4 quadrant. Before that, obviously you ensure your ultrasonography, everything, that you have a thick sclera. So some or other day, if you do only limited one, you are going to, patient is going to come back. So once you are going in, might as well take care of all 4 quadrants. Okay. We change our approach now.
So Dr. Natarajan, would you do nanophthalmic eyes? I think Dr. Naresh also has a lot of experience with nanophthalmic eyes. So do you do inferior only, or all 4 quadrants at the same time? I think Naresh also does the same thing about just inferior.
Anand, actually, there are 2 things. One is for the prophylaxis for prior to the cataract surgery, and second one is for the exudative RD. See, our first approach is basically for in all these nanophthalmos in prophylaxis to phaco. So in that case, we do only 1 quadrant. So it usually reduces the IOP, deepens the AC, also makes the life better. I think we have compared that, and we have published also in AJO. And now we have recently published 146 cases of nanophthalmos actually. So in case where there is an exudative RD, we usually go for 2 quadrant. Usually the superior quadrants are preserved actually.
Yeah, that's
And
what.
we don't do a complete sclerectomy. It's a 2-flap actually. The superior flap is raised, and then we go for a deep sclerectomy, which is around 2 by 2, and then we cauterize the edges of the deeper flap, and then drain and close.
That's called subscleral sclerectomy. So that was
Yes.
So excellent. Are there any more questions to Padmaja? Thank you, Padmaja.
Here actually axial length was normal. So this is again an axial length normal with a thick sclera. So that's how it becomes a type 2 type of uvula.
Correct. Those are 3 types that have been described. Type 2 with normal thickness. So that is fine. Then we'll move on to Dr. Naresh. Naresh Babu is senior consultant head at the Retina Service, Arvind Eye Hospital, Madurai, prolific surgeon. It's a pleasure to introduce Naresh, and Sai, he will be talking to us on FEVR and retinoschisis associated arteries. So Sai, can we have Dr. Naresh's videos on?
Thank you, Anand. Thank you, VRSI, for the opportunity. Can I have my video? The second, yeah, first video, yes. So we'll just talk my experience on what do you call this retinoschisis. We don't very commonly come across retinoschisis RD. Maybe in total we would have operated 10 or 15 cases in all these years. And usually I prefer a buccal vitrectomy because in case of FEVR RD, it is a bit difficult to identify the outer retinal break, because the RD can happen because of the outer retinal break or inner retinal, the full thickness break. So when you are not able to identify, usually we go for a buccal vitrectomy, and our preferred is usually the 42 band. So in this case, we go for vitrectomy. The most important thing is the vitrectomy is similar to all the other vitrectomies, but the basic difference is inducing the PVD. So there are many people who use ocriplasmin for inducing the PVD. In this case, we induce PVD with a different technique. I'll just come to that later. And the second important thing is never cut the skytic retina. It's always better to preserve the skytic retina, and it can be just drained, and we can inject a silicone oil. Usually, most of these cases, the indication for the retinoschitic RD is varied. Actually, in this case, it's usually the macular involving retinal detachment. So but there is no role for prophylactic laser therapy in these cases, because it's detrimental for. So in this first case, we just induced the PVD, drained the skytic retina, then we did the laser and closed with the silicone oil. And the second case is an interesting case. We'll just come to that. So the buccal is tightened, but otherwise we usually don't use buccal in many of these cases. So silicone oil is injected for this case. And usually the retinal detachment is slowly, the visual progression is not that, deterioration is not that rapid. So this is a case, a very rare case we have seen, where we had a retinoschisis with macular hole. Optic disc pit. Usually we follow 3 techniques of optic disc pit. Usually in this case, we have done both the ILM peeling technique. You can see the peripheral schisis, ILM peeling technique, as well as the scleral plug. So we used the visco, the tricart assisted PVD induction. We used something called megavis technique. Actually, that particular portion is missed in this case. So the ILM is filled with BBG. So care is taken. Usually there is no deroofing of the macula happens when you are peeling the ILM. So here we stuffed both the ILM as well as the sclera into that. So after the fluid air exchange, usually I stuff the ILM into the optic disc. Then a partial thickness scleral flap is taken. So you can see one of the ports is converted to 23, because to negotiate this sclera into the vitreous cavity through 25 gauge is usually difficult. So to overcome that, usually one port is converted in 23 gauge, so that the negotiation is easy. So we just inserted the sclera. Many people keep the sclera over the pit, but I feel happy if I plug it. So we can see when we fit it, yes, it snugly fits into the sclera. And finally, SF6 is injected. For the last almost 10-15 years, I've been using only 2 cc, 100% SF6. There is no dilution of the gas in this, no mathematics involved, because it expands ideally for the eyeball. So we have never
Naresh, we're not hearing you.
Yeah, we can see the video though, but we can't hear Dr. Naresh Babu. I think your connectivity may be an issue.
He's not muted.
So Sai, can you pause the video here?
Yeah. Naresh, we're not hearing you. Your audio has suddenly gone off.
Can you hear me now, Anand?
Yes, yes, you're back.
Yeah, just go back, Sai, slightly behind. Yeah, you can play from here, no problem. Slightly forward, yes. So I think we stopped here. So we usually inject to 2 cc SF6 100% without any dilution for all the cases. In fact, if we are using C3F8, we use 0.8 cc 100%, no dilution involved in that. So never had any problem with the raised IOP. So the most important thing is people are using ochriplasmin for inducing the PVD in case of retinoschisis, because you should not damage the sciatic retina. So what we usually do is something called megavis technique. In this, after staining the vitreous, we inject the PFCL. So under the PFCL, usually I use Stanos and just to roll the vitreous into the periphery so that you form a nice ring. We call it as a megavis. Just once the ring is formed, you can use the forceps. And once the PVD starts inducing, you can find the PFCL seeping under the vitreous, and especially in all the the pediatric cases, we get a wonderful PVD induction. So without any much damage, without using any PVD, we can go for the the PVD induction in these cases. And this is a case of FEVR. FEVR, I think the retinal detachment rate in our cases is around 20% when we have published way back in 2000s. So the basic problem is, while inducing the PVD, what we have is the line of attachment in the periphery. And when you are doing the line of attachment, and if you induce the PVD, you can see the peripheral breaks forming. So that's one of the most difficult thing actually. Sai, can you stop this and go for the next video? Sai, yeah. So I just stop with this and go for that. Yeah. So this case actually we operated 4 years back, and 3 years ago the SOR was done. But recently, after 3 years being stable, this is a single-eyed patient. The patient developed the detachment, and you can find, in spite of doing a complete vitrectomy, there are a lot of vitreous left in the periphery anteriorly, and also the membranes forming. And while doing that induction of the membrane peeling, we can see some additional breaks are forming. And temporally, if you see, otherwise it's a clean case. So we can see a lot of vitreous forming over the, membranes forming over the peripheral vitreous. This was a buccal vitrectomy case. We can see the membranes forming. So we just tried peeling the membrane and just trimmed the membrane. And after this, so the basic problem is, in spite of staying stable for 4 or 5 years, these cases redetach. So at the end, we injected PFCL. A complete endolaser was done, and the peripheral anterior vitreous was completely removed, and we did the endolaser. Then temporarily, the 5000 oil being a single-eyed patient. And there was one additional retinotomy just in the posterior retina, which was also barraged. And it was used as a drainage retinotomy. So the basic problem in all these cases, PVD induction. So usually people prefer in the Western world ochriplasmin. I don't know how many of us we use ochriplasmin, but we use this technique called megavis, where you induce a PVD with the Tanos, which gives a very good result in these cases. I think for want of time, I'll stop with that. Thank you, Anand. And
thank you, Naresh. Great bunch of videos. Dr. Charles, any comments, any pearls on spices and FEVR?
Yes. I never use ochriplasmin in any patient for any reason. 1.5% of the eyes, the vision goes dark. There's dissolution of the photoreceptors, even the zonules. 100% of the non-human primates in the preclinical work had zonulolysis, but worse than that, the ERG is extinguished. So I've never used ochriplasmin anybody ever. It's dangerous. 2, in kids with retinoschisis, they don't have a PVD, and I use PFO, but instead of using the PFO intraoperatively to create a PVD, I put the PFO in and and the fluid slowly comes out. I laser the brakes. Then when I come back in 2 weeks, the entire PVD has been created because the posterior vitreous cortex floats on, and this is true on round hole detachments, young myopes, for example, not just schisis. So I never aggressively make a PVD the way so many people do and make numerous retinal breaks, as was alluded to. I put the PFO in, and when I come back in 2 weeks, instead of removing the PFO with the soft tip cannula, I remove it with the vitreous cutter, because now a PVD has been gently created, and it's a very nice technique.
Thank you. Thank you. Yeah. Any other comments from our panelist, Dr. Pramod Bende, on if your take on PVR?
Basically, coming to retinoschisis, not necessary that every eye you need to remove the inner layer, but there are situations in which is more common. Sometimes you cannot identify, there is a detachment, but cannot identify outer layer breaks. There can be very, very tiny breaks, and generally they are along where the split is. So unless you remove the inner layer, you just cannot see those breaks. So you cannot be rigid that I will not remove or I'll remove all the cases. You have to take a call case to case basis.
I agree.
Dr. Naresh, I have a question. In which cases do you usually put a scleral graft in your optic nerve head pit cases? Were you always using that, or when did you switch using to a scleral graft?
Raja, actually, recently we have compared 3 techniques: the ILM, the sclera, and just the ILM peeling alone. Actually speaking, the closure of, the settling of the macula happens much more rapidly in case of scleral plug. But when we see the visual outcome, it is better with the ILM plug. The probable reason we are giving is like when we are inserting the plug into the optic pit, I think we are damaging some of the nerve fiber that leads to relatively poor vision in case of scleral plug. So now actually literally we have moved to ILM alone, but it doesn't close that rapidly, but takes a longer time actually. So now our most preferred is ILM.
Yes, Dr. Charles, what would be your comment on that? There's been a lot of enthusiasm over the last decade about plugging the optic disc pit. It seems to may not change the final outcome, but maybe more rapidly settle these optic disc pit detachments, which usually tend to happen fairly slowly.
I historically did the Mort Cox technique, which was vitrectomy and then real light laser on the temporal border of the disc, not with PFO in the eye, not with air in the eye, because if you do that, you'll get a nerve fiber layer defect. So you're trying to treat just the pigment epithelium with very light laser on the temporal border of the disc. So that's what I did for 30 some years since Mort Cox reported it. When ILM peeling came along in macular hole surgery, then I added ILM peeling thinking it made the retina more compliant, but I didn't fold it over and put it in the pit. More recently, in just a handful of cases, not enough to have data. I mean, they worked, but there's just not enough there to make a pronouncement about success rates, is I folded over the ILM that was in the PM bundle, so it remained attached at the temporal margin of the disc, folded it so it's upside down and on top of the pit. And so it seemed it was a reasonable thing to do, but I don't have enough experience to comment that it has better outcomes or faster absorption of fluid.
Yeah, a couple of cases I had when we peel on the macula, had a deroofing, and I landed up having a full thickness macular roll. So I stopped at least. Now, if at all I had to do, I do that fovea sparing ILM and not definitely peel over the fovea.
I agree with Dr. Pramod. In the last 7 cases, which I have done over 3 years, I have done the ILM flap onto the pit and done a foveal sparing peel. The resolution is slow and visual improvement takes place over time, but it really stabilizes well. And I've not ever done laser across the maculopapular bundle. So it has been just a peel and a flap. In fact, double flap on the pit.
I just take a temporal flap and just move it across the over the pit, so it works fairly well. So, any other?
Anand,
yeah,
Anand, I've got a question actually for the panel, because see, now we are taking all our FEVR cases where we have done prophylactic laser for the holes. Actually, our experience has been very bad, because even if there is a hole, just to leave it, or if you want to go for a prophylactic buckle, and never do a what you call aggressive laser for FEVR, even if there is a hole, because We have seen recently in the sense bilateral case has been stable for 4 or 5 years. Suddenly one consultant felt that he has got breaks. We have to laser. Both eyes went in for RD. And from 6.6 at the end, we could get only 6.24 and 6.18 both eyes. So we don't advocate laser anymore in our cases. So what is the call on prophylactic laser in FEVR, which is, we feel that after comparing all our cases is not that good.
What would you say, Dr. Charles? Dr. Naresh is talking about FEVR where there are holes being seen and they didn't have a great experience lasering those prophylactically.
We're talking about the other eye of a PVR eye?
Oh, FEVR, generally.
FEVR.
FEVR eyes.
I'm sorry, fever.
Fever, yes.
Fever. I don't have enough experience to really comment on fever.
Okay. Anybody, Dr. Pramod, Dr. Mahesh? FEVR with holes seen, experience with laser, prophylactic laser.
I have not come across cases with the prophylactic with the hole, but then like regular laser itself, what I would do is to support it with an encircling band and then do the laser, because I tend to think that it contracts and creates more trouble. So regular laser itself, I usually do support it with a buckle and then tend to keep the laser away from the fibers you should do. But I have not come across what Dr. Naresh was mentioning about a hole with the thing. I have not come across that.
Okay, Giridhar, what would you say?
What about just ischemic retina? I mean, just if you have an ischemic retina with no fibrous tissue, I don't think those cases do badly with laser. They do quite well with laser for years together.
But if you do not have a so obvious traction, basically laser is more for if you have an exudative component is not responding, that's the one part. But I agree with Mahesh, where if you have a break, you have a detachment, these are the eyes I would try to do buccal as far as possible. And probably this is the only case situation I would suggest. A couple of cases I did prophylactic buccal when I saw a bad experience with other eye. The second eye, which is reasonably better, had a significant traction, and I knew that is a matter of time. He is going to come back with a pulled retina somewhere. So 2 cases I did a prophylactic buccal, and they are holding on last almost 5 to 6 years now. So generally we don't advocate prophylactic buccal, but probably this is one of the indication I would do to just counteract traction. Laser or cryo, depending on whether you have a break or not, or depending on indication what you have, whether it's for exudation or whether it's for perspective.
So, Dr. Naresh, I have a question. You mentioned in your case that this laser caused retinal detachment after a few years, I guess.
No, the patient had hole, but we have never lasered the case. We observed for a few years. Actually, after doing the laser, within 15 days, both eyes detached.
Yes, so I have seen it, not in fever, but in stickler. If you use heavy burns in these cases, then somehow these are vitreopathy cases. The vitreous contracts, and they suddenly within a week to 10 days, they develop retinal detachment. So heavy burns should be avoided in these cases of vitreopathy.
That can happen in any case where you have traction, even diabetic tractional detachment, and you go close to the traction and you do laser there because of contraction due secondary to laser, worsening traction. It is very well known. So obviously you prefer as far as possible to avoid this.
Raja, just a doubt, Raja.
Yes.
No, in case of particular, see what is classically mentioned is optically empty vitreous. Even in such cases, we'll get a contraction of the vitreous.
Yes, so this was in one of my cases about 6 years ago, that once a regular laser, I mean, it was done like a regular laser as you would treat a, let's say a myope with a lattice. And then within 10 days, that child came back with retinal detachment. So I don't know whether we should be deliberately using lesser power compared to a regular barrage laser, which you normally would use. That's something which I would always recommend in these cases going on.
I would like to ask one question. Do you always advocate a belt buckle in any FEVR vitrectomy?
Yes, sir. In pediatric cases, we prefer, because it's very difficult to induce the PVD beyond the line of that attachment.
That attachment always, you can just trim it. You can't.
Yes. So when we pull it with the forceps or any other thing, we create more holes and it is more detrimental. So what we do is we try to induce the PVD anteriorly towards the attachment, but it is not happening unlike in case of lattice with holes. So we prefer to go for buckle in this case so that we can pin the vitreous and leave it without causing much damage to the retina.
I just wanted to bring this point forward.
Yeah, I also agree. This has also been my practice. I've also seen this situation where laser causes this thing. And this is one situation where I think FEVR lasers should not be in the hands of fellows. The faculty has to do it. It needs experience. Like the point Raja was making, heavy laser burns, you have to be very careful. Also, this is one situation where I think the need for encircling bands and even a broad buckle plays a role. Additionally, compared to diabetic vitrectomies, FEVR can be progressive, and the progression is unfortunately in the periphery. So you have a very pathologic periphery, it's a vitreoretinopathy. So there's a lot of pathology happening, and I think a buckle in this situation can be protective going forwards for the patient in the long run.
I think Dr. Mahesh wants to add something.
Yeah, Mahesh.
In select situations, I've actually done a scleral imbrication of the temporal sclera, because the buckle pushes it inside, but we need to shorten the sclera and shorten the traction. So in select situations, I have done temporal imbrication of the sclera, shortening it, flattening the fold, but in very select situations.
So thank you. We've had a wonderful session. It's been truly exhilarating. A lot of the questions that we've discussed and the situations have also come up in the audience questions, and there's been a great encouraging response. I'd like to thank, Dr. Steve Charles. Oh, Sangeet, you have a question? Sangeet?
No. It's fine.
Okay. So I'd like to thank Dr. Steve Charles for a wonderful lecture and so promptly agreeing to be with us so early in the morning. It's early in the morning for him. And he's always been absolutely we're very grateful for engaging with us, the Vitreoretinal Society, and all your insights have been wonderful. I'd also like to thank all the speakers for their excellent presentations. It's not been easy to bring these together. I understand in these difficult times. So thank you very much for your efforts. And I'd really like to thank all our eminent panelists for their insightful interactions. And thank you very much. Thank you again, Dr. Steve Charles.
My pleasure. It's wonderful to interact with my colleagues and friends. And I wish you the best in this pandemic.
Thank you.
Take a group photo.
Do the same for
screenshot. You can take a quick group photo, Raja. Yeah, I got it. Thank you. Thank you. And most of all, I'd like to thank all the members of Vitreoretinal Society and others who have joined us and been with us for these 2 hours. There's been a huge response. I can see that already. And we'd like to keep up this series. And thank you very much. I also like to thank Alcon for supporting us too. And thank you very much. Good day.
Thank you very much and good luck. Bye.
Thank you, Anand. Wonderful. Shobit, congratulations as the president of VRSI.
Thank you.